there. They have already joined. And I will just explain the semi-final rounds, the format today. So we have 15 teams, and this is how we are going to finish the semi-final today, out of which, so total of 15 teams, and we have 4 different rounds. First is chest and cardiovascular. Second round is a neuro, which will include head and neck, brain, and spine as well. Then abdominal imaging, which includes pelvic, upper abdomen, lower abdomen, and pelvis. And fourth round is a musculoskeletal imaging round. So each of the 15 teams will first face the questions from the chest round. Then they will move to the faculty 2, which will cover neuro round. Again, 15 teams will face one question each. How the question will happen, that I will just describe. So all teams first face the chest round, move to the neuro round, move to abdominal round, and move to the MSK round. So once the score is available, we will have top 8 teams after these 4 rounds. So then only these top 8 teams will be able to go to the next round, that is the spotters round. And the spotter round will be open to all the teams. There will be total of 20 spotters, and that will decide the top 5 teams for today, which will go to the national finals at Chennai during AOCR quiz. So the first 4 rounds, that is round 1, round 2, round 3, and round 4, are based on short cases. So the faculty will first cover the first 15 teams, then the second round, then third round, then fourth round. So there will be 1 or 2 slides, and there will be a short case displayed on the image on the screen, and faculty will show the images, and you have to give the correct finding and the description. But the time you have is only 2 minutes. So you have to start describing things as soon as the slide is available on the screen. If the answer is completely correct, description is correct, then you will get +2. If it is partially correct, then +1. If your correct answer is completely correct or differentials are completely correct, then you will get total of +5 marks. So these are the different components. And if the diagnosis is partially correct, then +3. And then if you have given the correct answer, then you will be asked one related theoretical question. If that is correct, then you will get +3. And if it is completely correct, +3. If it is partially correct, +1. So in a single case of chest or a neuro, you will be able to get the maximum of 10 total marks. 10 means +2, +5, and +3. So based on these 3 components in a single case, you are able to take score as much as 10 maximum points in a short case round. So the same thing applies to the neuro round, same applies to the abdominal round, same applies to the MSK round. So at the end of round 1, round 2, round 3, and round 4, you will be able to score total marks out of 40. 10 marks in each of the 4 systems. Is it clear? And this partial scoring is only when the answer is partially correct, and then faculty is going to let us know when the answer is absolutely correct or answer is partially correct. And another important thing, if you have not given any description, any diagnosis, then the third component, the answer to the related theoretical question, will not give you any marks. So these +3 and +1, +3 or +1, that is the theoretical question, is only applicable if you have given the correct diagnosis or if you have given the correct description. So this is important to understand. And once the initial 4 rounds are over, then we move to the spotters. There will be total of 20 spotters, but only top 8 teams will be able to go to this second component of the semi-finals, that is the spotter round. Only top 8 teams. And the team, these 20 spotters will be displayed, and it is open to all the 8 teams. And the team with the fastest response, as soon as it is, you don't have to respond, you have to just raise your hand, nothing to speak, and we will decide that who is the fastest responder, and he will get the chance to respond. If the answer is correct, +1, or if it is partially correct, +0.5. If the answer is wrong, then minus, so negative marking is there. That is very small, but it is there minus 0.5. And if no answer, then 0. So total 40 marks in the short cases and total of 20 marks in the spotter round, because plus 1 for each correct answer. So the total marks today, which is available in all the rounds, is 40 plus 20. That is total of 60 rounds, and that will decide the top 5 teams today, which will go to the AOCR finals. So if there are any queries, you can ask.
Um, there is somebody called Farhana's iPhone which has joined. Then there is somebody called Gaurav Sharma who has joined. Gaurav Sharma is one of the faculty, sir.
No.
No,
Please,
5 faculty only.
Ankit bhai, please remove Gaurav Sharma.
Okay, sir.
Sharad sir is there. Shrijita ma'am is there. Dr. Sapna ma'am is there. Sanjay sir is there. Tharani ma'am is there. Gaurav
Yeah, so
Sharma.
that's all.
Okay. Now, Ankit bhai, if you want to admit anybody, you can interject loudly and ask us if it seems very important, or you can message me or Nidhi ma'am or Ankur sir. Sir, will there be any, Nitin sir, I have a question. Will there be any negative markings in the cases?
No, in the cases, in short cases, there is no negative marking. So feel free to answer, even if you know little about the case, but don't uh, create pause, because we have limited time of 2 minutes for each team. In spotters, there is negative marking, so be careful. That is minus 0.5 marks for a wrong answer.
Sir, one more query. If somebody in spotter round, if somebody puts up the hand first and doesn't answer,
So zero only, zero.
No, sir. No, sir. We have
but
to
Negative.
that should be
negative
negative, na?
marking.
Negative.
Because if it is
Negative
putting up
marking.
his hand and not
Negative.
answering, it should be giving negative.
That's
Negative.
Yes,
negative
yes.
marking.
Somebody puts the hand up and doesn't
Does
answer.
not answer at
Then
all.
negative.
That is
Then if,
negative.
Then
That
negative.
should be
if,
negative, not zero, sir. Yes, sir.
if someone doesn't respond or
Hmm.
doesn't do anything, then it will remain zero only.
Also, we will be very strict regarding any form of cheating. And when one-to-one short case is going on, the team members should be continuously looking at the screen. Even if
With
you try
videos
to
on.
look, you have to look at the camera and your screen. If you try to look here or there or anywhere else, it will be taken as cheating. We will consider that you are cheating or somebody is trying to help you. In that case scenario, that case you will lose that case entirely immediately, and it can also lead to you getting expelled from the semifinals. So as and when you are answering, please make sure you look at the screen at all times. At the most, you can look and talk with each other, but your audio should be on and you should be looking at the screen. Don't look anywhere else. If we suspect, other than this, if we suspect anything that has to do with cheating, or if we suspect that cheating is being done, quiz masters will take a call. There are 4 quiz masters who will take this call: Dr. Nitin sir, Nidhi ma'am, Ankur sir, and Gurpreet sir, and strict action will be taken.
And the same thing applies to the spotter round also. There will
Yes.
be a very 20 seconds window when you will answer. Delayed response, delayed time will be taken as doubtful. So be careful. So anyone has any query or doubt about the format or the marking system?
I am seeing techie tods. Somebody has put something in the ear. Please remove that. Both of you have to remove. No audio device is allowed for anybody. For anybody, no audio device is allowed. You have to use your computer screen only.
Yes.
Gurpreet sir, please check.
Yes, I am there.
Nobody, please, everybody show your ears. I'm really sorry for this embarrassing thing, but no kind of audio device within the ear is allowed at any point of time. This will be taken as cheating.
Both team members have to continuously face the camera. You are not allowed to look sideways. Please don't cheat, because any suspicion we have, strict action will be taken against them. Please beware. Throughout the quiz events, we have been harping on the same thing. So please beware. Harping will take strict action.
We still have 5 minutes. So if anybody has any questions, please feel
Okay,
free
so
to
yeah,
raise
feel
those
free to
questions.
ask. Yes. And in the meantime, I will just introduce the quiz faculty.
Yes, sir. Please,
So
please.
the round one will be covered by Dr. Sanjay Dhawan, who is Chief Radiologist and Group Clinical Director with Clear Medi Healthcare at Gurugram and rather at many other places. So Dr. Sanjay Dhawan will be covering chest and cardiovascular radiology today in the round one. Round two will be covered by Dr. Sapna Singh. She will be covering neuroradiology, including spine, head and neck, and she is professor at Maulana Azad Medical College at New Delhi, and she is an excellent teacher and uh, is teaching radiology students across the country for last many years. So Dr. Sapna Singh will cover the round two. Round three will be abdominal radiology, where we have two faculty. Dr. Sharad Maheshwari will be taking posing questions to team 1 to team 8. So first 8 teams will face Dr. Sharad Maheshwari, who is consultant radiologist at Kokilabin Hospital in Mumbai, and he is abdominal radiologist and has multiple presentations and publications in that subject, and he has this blog spot on abdominal imaging as well. So Dr. Sharad Maheshwari will be covering team abdominal radiology for the team 1 to team 8, and team 9 to team 15 will be covered by Dr. Tharani Patta. Dr. Tharani is Director of Abdominal Radiology at AIG Hyderabad. She is an alumni of CMC Vellore, and she has received multiple awards and publications. She is shortlisted as semi-finalist for the Aunt Minnie's Most Effective Radiology Educator Award for this year. So Dr. Tharani will be covering abdominal radiology for the remaining teams from team 9 to team 15. And at the end, musculoskeletal radiology will be covered by our fifth faculty, Dr. Shrijita Ghosh. Dr. Shrijita is senior consultant radiologist at Apollo Multispeciality Hospital at Kolkata, and she is a familiar name in musculoskeletal imaging and conducts learning courses for the residents quite frequently. So Dr. Srijita will cover the MSK round, that is the last round, that is the fourth round. And followed by this, there will be spotter round, as I mentioned previously. So best wishes to all the teams, and we will start with team one, and we will start with Dr. Sanjay Dhawan for the chest radiology.
Nitin,
Yes, Dr. Sanjay.
where is this icon for sharing screen here? This seems to be.
I will stop so that you can share now.
No, where is that icon?
It will be a green icon in the bottom, middle
Okay, yeah,
bottom.
I got it.
Hmm. So you can, I think, Gaurang, we shall start.
Yes, sir. We can start. And
Yeah,
I
it is
just
just
last one
7.
request. Last one request. I think we have just 1 minute. For the short cases, it will be total 2 minutes given to all teams. So you have to start speaking. If in those given 2 minutes you are not able to finish off, including the theoretical question, that attempt also will go away. So if you are very slow in answering, then beyond 2 minutes we won't be able to extend the time for you. And then please don't complain that we were not asked the question or something like that. And keep on talking, don't stop. We can start.
Yeah. So, good evening, everyone, and thanks to the organizing committee for inviting me to do this lovely time to interact with the residents. So, that's me. won't spend much time here.
So
And
just a minute. Go back. Go back. Team one. So Ankit, you have to pin Dr. Sanjay Dhawan as well as the team one.
Sure, sir.
So team one will be facing the first
Team
question.
one has to unmute. When your turn comes, each team has to unmute, please.
so is team one ready?
I'm not able to see team one.
I can see team one.
Okay,
Yes.
sir. Yeah, okay, they are pinned. Okay, got it, got it. Yes, sir, we can start.
Yeah, perfect.
So good evening, everyone. Thanks to the organizers for giving this chance to me. And it's a lovely opportunity to interact with the residents. So I will be doing short cases, 15 in all. And the first one is this 26 years old female patient who's presented with fever. You might have to roll this window down so that so please start speaking because time is ticking.
There are multiple round to oval shaped
Louder, please.
hyperdense lesions. There are multiple round to oval shaped hyperdense lesions noted in bilateral lung lobes, predominantly in the peripheral zones. No obvious hepatomegaly is seen in the coronal section, and there is no
So
obvious.
are you able to see the soft tissue windows in entirety, or it is covered by that zoom?
No, sir, we are able to see.
Good.
We are able to see, sir. The differentials of the lesions could be metastasis because of their numbers and speculated margins. In few of the lesions, we can see speculated margins. And in some of them, there's a very thin rim of ground glass opacity surrounding them, but no obvious mass lesion.
So give me your definition.
Adrenal. On the coronal section, just above the kidneys, we can see a heterogeneously iso to hypodense mass lesion, likely adrenal.
You can ignore that. So differential, you have told me one is metastasis.
Yes, sir.
And
the other differential could be.
The other person should not be in same room.
Yes, sir. He's a
Team
patient
X-ray, there
attender,
is
sir. We would just, yes, sir. We would just,
there is a third person in the room. Ask him to
yes,
move
sir.
out. X-ray.
Yes, sir. Patient attender just came. We will ask him to move.
Dr. Sanjay, I think so time is over.
yeah, so I've got only one diagnosis from you, metastasis, right? So, so I don't think I can mark it as correct at all. There are multiple nodules, all right. First, on lung windows, you don't call nodules as hyperdense. They are nodular opacities, all right. And this soft tissue window reveals that, there is a hypodense lesion heterogeneous in the left subscapularis region. So this is a subscapularis abscess with septic emboli. And I gave you the history. One, it is 26 years, and second, it is fever. So the correct diagnosis is subscapularis abscess with pulmonary septic emboli. All right?
Yes.
Right, then. Is the next
Dr. Sanjay, this will be 0
Sanjay
marks?
sir, please
Yeah, 0 marks.
tell the marks. Yes.
Okay. Next team.
So we have to pin team 2. Ankit bhai, you have to do it each time. Please help us in that. Unpin team X-rated and pin team 2.
Yes, sir.
Please switch on your video.
Sir, team 2 will get pinned. They will switch on the video and the audio also. Teams can stick due. Okay, great.
So can I proceed?
Sir, we have to change the slide. Now I think it's still on.
Yeah, I'm doing that, but why is it not moving? This window is a problem.
Hmm.
So
Okay.
36 years male with history of fever. First, I'm going to give you the X-ray, describe differential, and then I will give you the CT.
Frontal radiograph of chest shows ill-defined opacities in bilateral lower zones in the paracardiac region. Cardiac sellout is not obscured. Diaphragmic sellout is also not obscured. Cardiac size is normal. And bilateral CP angles are clear, and both the rest of the lung zones are clear, and bone window is bones appear normal.
So what is your conclusion?
And retrocardiac view opacities are there. 36-year-old male with fever, so could be infective. One possibility would be infective utilization.
Infective.
Yeah.
Okay, and anything else?
36-year-old male with fever and right lower zone also opacity.
Can we move to the next slide, sir?
Multiple opacities is noted in bilateral lung fields and bilateral lung parenchyma with central dense opacities with surrounding ground glass opacities appearing as reverse halo in predominantly involving bilateral lower zones. One differential is organizing septic embolia. One differential is organizing pneumonia.
Mm-hmm.
Reverse haloitis. Sorry, sir, this is not reverse halo. Halo sign with.
The time is over.
Diagnosis quickly, can you tell me? Okay, so firstly, it is not, it is basically halo sign. It is not reverse, right? And this is classical of invasive aspergillosis. Okay. So I think, Dr. Nidhi, we can give them one mark because they could pick up some findings on the X-ray. It's going up to the infective, but that would be all. Next team.
Sir,
Ankit, please pin Techie
Yeah, take it out. I can see. Are you ready, take it out?
yes, sir. Can you hear me, sir?
Yes, I can hear you.
Sir.
So this is a radiograph of a 70-year-old male patient who has come with cough and shortness of breath.
Sir, radiograph chest frontal view shows the blunting of the left costophrenic angle, and there are multiple ill-defined airspace opacities in the left lung, predominantly involving the middle zone and the lower zones of the left lung. There's evidence of volume loss also in the left hemithorax. The few nodular lesions are also seen within the airspace opacity.
Nodules as well as masses are seen.
Nodules as well as nodular ill-defined airspace opacities are seen.
Interstitial spread.
There are multiple nodules, and there are interstitial reticular nodular opacities seen.
What else?
With associated. Sir?
What else? What one important finding? There is left-side pleural effusion.
Left-sided pleural effusion, I've said, sir.
Effusion without mass.
So what is your diagnosis or
the diagnosis is a malignant etiology, a lung carcinoma with malignant pleural effusion.
There is not much mass effect, so there can be a malignancy with the lymphangitic spread and a malignant diffusion in a 70-year-old male.
Would lung carcinoma cause kind of reduction in the lung volume?
Yes, sir. If there is an endobronchial growth, it can lead to collapse of the airway.
That's correct. But look at the CT.
There's circumferential nodular pleural thickening that is noted. Malignant mesothelioma is my differential after looking at
First
the
differential will be malignant mesothelioma.
nodular pleural thickening, circumferential, pleural metastasis can be my second
Sir,
differential.
time is over.
Good.
Dr.
Yeah.
Sanjay, time is
You are
over.
correct. This is mesothelioma, and well attempted. But only thing is that you probably picked it up. Why it is unlikely to be metastasis?
Sir,
Because I don't see anything on the left side.
Sir.
Right?
Unilateral.
Yeah. So next team is, so I think not
theoretical question, sir. You want to ask any theoretical question?
No, that's enough. I think you've done well on this. So this is the correct diagnosis, Nidhi. You can mark it.
So findings में 2 and diagnosis में 5, right?
Yeah.
But what about theoretical question?
What about the theoretical question?
Another question was there, why it is not metastasis? No, so you can give answer for that.
Yeah.
So that will be marked as 2 or marked as 3 or marked as 0.
That is marked as 1. Because I asked, they could not tell the answer.
So what
Yes, they didn't answer it.
Yeah.
So 0 or
0.
Okay, 0 for the theoretical question.
Yeah.
And
We have total 7.
5 for the diagnosis.
Right.
Okay.
5 plus
that
2, right?
Additional question was not given as an additional question.
You
rather.
didn't have enough time also left, actually.
Yeah, we didn't have
You
enough
didn't
time.
have time
I
for
asked
the
you enough
question.
questions on the X-ray and then also CT.
Sir.
We cannot mark it as additional
What are the-
question. We have to ask it. And you didn't answer it right. So that's why
Nidhi
you're
ma'am,
not
what is the final scoring out of 10 for the
7.
team?
7.
Seven.
7.
Out of
So
10.
Dr. Nidhi, you can just repeat for team 1, 2, and 3 till now.
Okay.
So that
Team
everyone is
1.
clear about their marks.
Team 1 is 0. No findings. Differentials wrong. Team 2 is only 1 because they told certain findings on chest X-ray, but the diagnosis was wrong. And team 3, they told the findings plus the differentials, but wrong technical theoretical question. 2 plus 5, 7.
Okay.
Thank
Okay.
you.
Okay, team 4 now.
Neeraj, please pin Charak. Team
Can you
Charak.
move to team 4?
Yes, sir, we have unmuted, sir.
Neeraj, please pin them.
Sir, are we audible, sir?
Yeah, you're audible, but you're not visible.
Okay. So we can start.
Team 4.
I'm able to see them, Team Charak.
Okay,
Yes.
good. So this is a 55 years female patient, CT chest done to rule out COVID. And I've given
Yes, sir.
you
So,
multiple soft tissue window setting and 1 lung window.
Yes, sir. So in the representative axial section of the lung window, we see a well circumscribed lesion. The lesion is seen to cause cutoff of the lesion is in the right lower lobe superior segment, and it is seen to cause cutoff of the segmental bronchus, which is seen in the lung window. In the representative soft tissue windows, we see that the lesion is central in location, sir. There are no cavitations. There's one area of calcification that is noted in the center of the lesion. There's no macroscopic fat that is seen within the lesion. There are no speculations that are noted. And in the
So I can tell you small speck of fat as well. Okay.
Sir, yes, sir. So if there is macroscopic fat and if there is calcification, our diagnosis in this case would be a pulmonary hematoma, sir.
Any differentials?
Sir, differentials in this particular case, we would consider other benign lesions, sir. Benign solid lesions with fat and calcifications. क्या हो सकता है? Fat calcification. So it is because of the fat content, it would be a hematoma. That would be the first.
Okay, so the question I want to ask you is, how will you proceed? You'll just call it hematoma or you will do something else also to confirm?
For the
No touch lesion. No touch lesion.
we do not generally go for biopsies from this. This is a benign looking lesion, and we do not touch it. It's a no touch lesion.
Right.
Yes.
Fine, good. So Dr. Nidhi, full marks on all counts.
Okay, sir. Time is also over.
Yeah.
Okay, sir.
10 out of 10?
Yeah.
Ma'am? Okay.
Who's next?
Hello, sir.
Hello, who? What team are you?
Adamalengas, team 5, sir.
Team 5. So team 5, I'm proceeding with you. This is your X-ray. This is a 27-year-old female who came for a routine pre-medical
Ankit, you have
employment.
to pin team 5. Pin team 5.
No, they said they're here.
No, no, pin. We need to look at them continuously.
So what is the abnormality here? Quickly.
Ankit ji.
So
Team
mild
one.
widening of left side paratracheal stripe is noted.
Something else actually.
Sir?
Something else. So at least you can say that there is blunting of the right CPM, right? So I have to reveal the answer at this stage because the following CT will only confirm it. And then I will ask you a question. So this is a solitary pulmonary nodule, this one. And I have given you a zoomed image as well. And you don't believe me, then this is the CT. All right.
Oh, okay, sir.
So you got a diagnosis wrong, but I will still ask you a second question. How will you kind of go ahead as per Fleishner Society guidelines for evaluation or management of this nodule?
Based on size of the nodules, sir.
7 mm.
Follow-up CT in 6 months. Follow-up CT in 6 months.
All right. So it fits into the category of intermediate solid nodule, right?
Yes,
There are
yes,
no
yes, sir.
circulations and the patient is 27 years old, asymptomatic. So this is a low risk kind of nodule.
The
So
time is over.
yeah, 6 months follow-up CT is fine, right? So the diagnosis was wrong, but the answer was right.
But we cannot give, sir. We will stick by the rules.
Correct.
Not
as much, yeah.
Right, Nitin sir, Nidhi ma'am?
Yes, that's
If
what
they
Dr.
get the
Nitin decided
diagnosis
that.
correct, then only they will be awarded marks for the answer, right?
I totally agree
Yes.
with you.
Yes.
Yeah.
Well, only responding to theoretical question will not help.
Yeah. Fine.
So how many marks,
And
Nitin?
Ankit, you have to pin the team. We need to see the video throughout the
Charaka,
responding
you
team
have to
should.
unpin, and now you have to pin team 6. And what is
And
the
other teams can kind of switch off their videos temporarily.
No, sir, that is
Not required, sir. Not.
not required?
no.
Oh, sir, we need the videos on, sir.
All right.
All we need the video on. I think what is the marks of team 5, ma'am? Can you speak out loudly just to be
Team
clear?
5, of course, 0 marks.
Okay.
Yeah.
Thank
No
you.
findings, no diagnosis,
Okay.
and of course, we are not giving any marks for the theoretical question if the initial 2 diagnosis and findings are 0.
Okay.
So who next? Team 6.
The team 6 is on pinned, so you can proceed to the next question, sir.
Okay.
Are we audible, sir?
Yeah, you are audible. So this is a single X-ray I'm showing you. 63 years old female who came to ER with chest discomfort.
Left side. Sir, in the chest radiograph, sir, I'm able to see the superior mediastinal widening here, sir. And again, homogeneous opacities involving the left side, left lower zone or left mid zone ka opacities hai, sir. Then I'm able to see LV type of cardiomegaly also, sir.
Right. So what is your diagnosis or differential diagnosis?
Sir, since because I'm able to see a cardiomegaly also, sir, and superior mediastinal widening, I first diagnosis will, and there is a left-sided effusion. Aortic dissection or aneurysm would be one of my vascular causes. Could be the causes.
Anything else?
Is
Because there is no CT to it.
Sufficient rupture. So it could be esophageal rupture can be a differential. However, there is no pneumomediastinum which is there, sir. The differential. Or it could be a superior mediastinal mass as such, sir, which is presenting like this.
Okay. Mass means what? Something else? Superior mediastinal?
Since it is seen both side of the mediastinum, sir, then lymph node will be the first probable diagnosis.
Right. So, I mean, you have picked up one finding correctly, which is the superior mediastinal widening. That is because of lymph nodes. But the critical thing here is you didn't pick up the missing right breast.
Sir. Post-mastectomy status, right side, sir. And
All
also
right.
one oxygenation tube is there. So it's
So this is basically a CA breast with recurrent mediastinal lymphadenopathy.
Sir.
And if you see very closely, there are some reticular marking. So this I suspect is lymphangitis.
Sir.
Right. So Dr. Nidhi, I mean, they got one finding correct,
Right,
but
sir.
they basically missed the gist of the X-ray. So I mean,
We can give them 1 marks,
yeah, correct.
Only
but
one.
only one. No,
Mark
there
for
is no
team
marks for
Dhanvantri.
the diagnosis.
Yes, you
So
can
team Dhanvantri 6, team 1 marks.
Yeah.
team 6 1 mark. Team 7, can you please spin and start your audio?
Team Bernard. Ankit ji, please pin team Bernard.
Yes, sir.
Ankit,
Yes, sir.
unpin Dhanvantri and pin Bernard.
So is team 7 online?
Yes, sir. Yes, sir.
Yes, sir.
Sandeep, this is your question.
I am provided with a frontal radiograph of a 70 years old male where I can see a homogeneous radio opacity on the left upper zone with the surrounding fibrotic strandings. Like I can see fibrotic markings surrounding the opacity, sir.
Okay. So what do you think is happening?
Just okay. The lesion is seen to touching the pleural surface and making an acute angle with the lesion, acute angle with the pleural surface. 70-year man. Left upper lobe mass, and we can also see a crowding of ribs on the left upper zone, sir.
Okay.
Yes. So we can
the CT.
Yes, sir. On CT, we can see a heterogeneous soft tissue lesion arising from the left side upper rib, causing a destruction of the rib. With the lesion is extending both intrathoracic and extrathoracic soft tissue component. With also there is a opacity. There is a associated collapse of left upper lobes.
Okay.
So we are going with the primary malignancy of chest wall, sir.
What else? There is one finding which should not can miss out.
Cavity. There's a cavity in left upper lung.
Yeah, the cavity is communicating with the bronchus.
With the bronchus, sir.
One more finding. And what is your diagnosis?
Cavity. Left up infiltration. Sir, left up. I can also see another massly, another nodule in the lower lobe, left lower lobe, sir. Chest.
Tell the diagnosis. Tell the diagnosis. Your time is over.
Upper lobe chest wall mass lesion with upper lobe infiltration and metastasis of lung.
Yeah.
The time is over.
Yeah. One thing you missed is that there is rib lysis.
Yes, sir. I said erosion of ribs.
Okay. Right. So this is a soft tissue tumor of the chest wall.
Yes, sir.
Primarily rising from the rib.
Yes, sir.
The biopsy came out as round cell tumor.
Yes, sir.
Right.
Yes, sir.
So anything else you can think of?
Ewing sarcoma, sir. Round cell tumor.
Ewing sarcoma is round cell tumor, right?
Yes,
so
sir.
what do you think should be the management? What will you do next investigation?
PET scan. PET scan to look for metastasis, sir.
Correct. We have already established that there are metastasis.
Yes, sir.
But the next investigation is PET scan, right?
Yes, sir.
Only thing is that on the X-ray you had picked up that obtuse angle and but
yes,
you
sir.
still choose to say as a pulmonary mass, not as a chest wall mass.
Yes,
so
sir.
that was the only thing wrong. So Dr. Nidhi, the description, we can give them half marks, and diagnosis, we can give them full marks. And the question
1 mark for the description, 1 mark for the
Yeah.
description, and 5 marks
Yeah.
for the diagnosis. And for
Yeah.
the question, sir?
Question also full marks.
Okay, sir.
Which is the next team?
1 minute.
Total, ma'am, total 9?
Yes, the total 9.
Total 9. Team 7, Bernard, total 9.
So 1 minute, Ankit bhai, you have to unpin team 6 and team 7 and pin team 8.
SMS Hospital.
हाँ, इन दोनों को अनपिन कर दीजिए. टीम 6 भी पिंड है, उसको भी अनपिन कर दीजिए. एंड SMS हॉस्पिटल टीम 8 आपको पिन करना है. Please identify yourself, team 8. Speak out loudly, so we'll see you before.
Yes, sir, we are ready. Sir. Start, sir.
Okay.
Team 8, SMS Hospital.
"72 years of lady, female patient, shortness of breath." I mean, you have to pick up the abnormality on the chest X-ray because the following CT is only confirmation of diagnosis.
Left CP angle is obliterated.
And sir, their relative cardiomegaly is noted. And sir, the aortic knuckle is prominent.
The calcification in the aortic knuckle is noted. Trachea.
And sir, there is
ET tube in the trachea.
so can be a pericardial due to pericardial effusion.
So time to give me a diagnosis or a differential diagnosis.
Straightening of heart bottom.
So can it be due to mitral stenosis? There is relative straightening of heart border as well.
No. How much time, Dr. Nidhi?
Sir, still 1 minute to go. They still have
Okay.
45 seconds to 1 minute to go. Because it's a single radiograph, that's why they have more time.
No, there is a CT also. So fine, I told you the CT will only confirm the diagnosis. So you have not picked up any finding correctly. You see there is loss of volume on the left lung as compared
Yes,
to the
sir.
right.
Yes,
Right?
sir, there is
You
loss.
told me ET tube is in trachea. ET tube is in the right main bronchus.
Yes, sir.
That's why it is kind of evolving collapse of the left lung. And when we did the CT, by that time the lung had totally collapsed.
Yes.
So the only thing required to be done was, tell me, where is the mistake here?
Sir,
That's
it
the
is
question.
ET tube should be reinserted or it should be
Yeah,
placed
so
properly.
just call the ear doctor and ask him to pull out the ET tube. In this case, it could have been done on the X-ray itself.
Time
Right?
is over,
So
sir.
no marks, Dr. Nidhi.
Okay, sir. Okay, sir.
0 marks.
So no
So
findings, no findings, no
No
diagnosis, and
findings.
theoretical question will not be given
Yeah,
weightage.
correct.
Okay, sir.
The next team.
SMS Hospital, 0 marks.
Yes.
please unpin team 8 and pin team 9. Team 9, please identify yourself.
Star Wizards.
Star Wizard, speak out loudly so that we can
Speak
see.
out.
Yes, sir, we can hear.
Okay.
Okay,
So
great.
here is your question. 75 years old female, weakness in right upper. Describe.
A 75-year-old male might have come with complaints of female with a right upper limb weakness. There is a soft tissue density in the right cervical region, might be extending to the right superior mediastinum with a positive cervicothoracic sign. And I'm not able to see, there is an erosion of the first rib and second rib as well. So the answer might be Pancoast tumor, superior sulcus tumor.
Well, that's absolutely correct. So my question to you is that which investigation is more beneficial for evaluation of Pancoast tumor and why?
Brachial plexus.
Yeah. So what would you do?
MRI brachial plexus to identify the nerves involved in the
Yeah,
Pancoast tumor.
and probably a CT to see the rib erosion. All right.
Yes.
So this is the CT. I mean, and this is the brachial plexus MR neurography. You could see that is infiltrating the brachial plexus and hence the symptoms. So full marks to team, what is it, 9?
9.
10.
10 out of 10
9.
for Star Wizards.
Star Wizards,
10.
9 team, 10 out of 10.
I
And they
think two
finished
teams
before
till
time
now
also.
have scored 10 out of 10, right?
Yeah,
Yes.
I think so.
Team
Great.
4 and
Yes.
team 9.
Great.
Yeah.
Yes. We will tell the scores once
Yes,
all
yes,
the
I
15 teams.
understand. Yes.
So
So,
next team.
team 10, please pin yourself. Please identify yourself. Speak
Yes,
out.
sir. We are here.
Okay.
Team 10, Mad Rads.
Yes, sir.
Sir, we can start.
Yeah. 11-year-old patient, male patient with fever.
Sir, we are provided with the frontal chest radiograph. We can see there are multiple round opacities with central lucency seen in bilateral lung fields, and we can see the opacity involving a right hilum also. With the 11-year-old male with the fever, I'm suspecting infective etiology. Is there any CT scan done for this case, sir?
Yes.
These are HRCT axial soft tissue and lung window images showing round consolidation with central cavitation. This might be likely due to infective etiology. Fungal can be given as a first possibility, sir. Vaginous granulomatosis can be given as second possibility depending on the other symptoms of the patient.
So you have given me two diagnoses. One is infective.
Yes, sir.
Fungal. Second you have given is vaginous granulomatosis.
Yes, sir.
Any other
This
diagnosis you want to give
septic
me?
emboli can also be there because I can see some feeding vessels are also seen in this densities, sir. Septic
All
emboli.
right. So what will you do next investigation to differentiate it between the three kind of diagnoses you have given?
We can get a endobronchial aspirate culture or blood culture. Vaginal dermatitis, we can get a antibody workup for that. Septic emboli, which should
have an infective bacterial culture should be positive. Should be having a focus of infection.
Yes. So what antibodies are you testing for vaginal?
PO RPO
AC inhibitor.
Priyanka.
Priyanka, sir.
Okay. So fine, I think you did very well on this. You picked up all the findings on the X-ray. Your differential diagnosis was absolutely correct. And this was an infective etiology, but I mean, I don't see anything to call it fungal. So this turned out to be a Cox.
Okay, sir.
Right? But I think we can give them full marks.
Thank you.
So full marks for
For
all the three
Mad Rads,
things?
Mad Rads, team 10, full mark. Ankit ji, pin 11, team 11, Star Crusaders. Star Crusaders.
Yes, sir.
Are you ready?
Yes, sir.
Okay. So here is your question.
Sorry.
14 years female with fever. This is a chest X-ray. Please describe the
A
findings.
plain radiograph of a chest shows only homogeneous opacities involving the left lung field and the round opacity. Around well-defined round opacity noted at the hilar region. No evidence of pleural effusion. Left cardiac border is obscured.
Obscured or not obscured?
Obscured.
Yeah, okay. For diagnosis, you have picked up majority of the findings.
Collapse of left lung collapse.
Left lung collapse. This is a classical. I cannot accept left lung.
Fever. Sorry, left middle of left pneumonia. Infective etiology.
Localize.
Some infective etiology involving
You have to localize.
Sir?
You have to localize. Where is it? There is no middle lobe on the left side.
Near the hilar region. Left lower lobe.
Okay. So the next one is the CT.
CT soft tissue window shows wedge-shaped areas of soft tissue consolidation noted in the left upper lobe with a node of cutoff of the bronchus, possibly upper lobe collapse with mass due to the mass lesion in the left bronchus.
This is the mass lesion.
Lymph node.
Dr.
You just
Sanjeev, the
told
time is
me-
over.
Yeah, you just told
Dr.
me
Sanjeev,
it's
the time is
necrotic node. So I tell you, and what will you do to establish a diagnosis? This is your question.
Yes, sir.
What will you do to establish a diagnosis? This is my question. Quickly.
Bronchial, endobronchial.
Yeah, endobronchial biopsy.
Biopsy.
Okay, so always all the listeners remember there is a classical picture. There is a luftishell here. There is opacity, which is what is characteristic called as wheel-like opacity, and CP angle is not is clear. The the left dome of diaphragm is clear. This is a classic left upper lobe collapse, right? So I cannot give you marks for missing this on X-ray. On the CT, you corrected yourself, but told me once this is a mass, this is a lymph node, this is a necrotic lymph node. And the biopsy was done, which revealed it to be a tubercular lymph node with consequent collapse of the left upper lobe. Right? So, Dr. Nidhi, I mean, you can give half marks for the picking of the findings, half marks for the diagnosis,
Okay,
and maybe full marks for the question,
Okay, sir.
if that is permissible within the rules.
Yes, sir. They at least told something on
Yeah.
the CT and the radiograph, so
Correct.
they will be given complete marks if they are theoretically given the right answer.
So that means they get +1 for the findings,
Yes,
plus
and
3
2.5.
for the diagnosis, and +1 for the plus
No,
3
sir.
for the question.
So they will get 1 for the findings in the X-ray, then 2.5 marks for the diagnosis, and 3 marks for the theoretical question.
Perfect.
So nothing like 2.5, it is +3 then. So 3 + 1, 4, 7 marks.
Okay. Team 11 Star Crusaders, 7 marks.
Team 12.
RMS
Yes, sir.
second year.
Yes, sir.
Please speak up.
Yes,
Ankit
sir.
ji, please pin. Yes, so we can start.
Okay. 12 question is 70 years male smoker, and these are the HRCT images.
We have axial lung window of a 70-year-old male smoker with cough and shortness of breath.
With honeycombing in the left lower lung and areas of emphysematous changes in the right upper lobe and right lower lobe.
There is interstitial septal thickening, and there is a picobasal gradient which is increasing in the basal.
Along with the history of smoking and emphysema, it can be combined pulmonary
We'll give a
CPFA.
UIP pattern of involvement of interstitial lung
Give me
disease.
one
And
diagnosis. Give me one.
CPFA.
Right, you're correct. Now your question is that what percentage of lung should be involved by emphysema in CPFE to call it CPFE? There is a kind of a percentage.
20%.
So the correct answer is more than 5%. Okay, if there is more than 5% of the lung is involved with emphysema, and there is interstitial thickening of any type, not necessarily UIP pattern, then it's labeled as CPFE. All right. So the first part, findings are correct, diagnosis was correct, but the question was not answered correctly.
So 7 marks, 2 for the findings, 5 for the diagnosis, and 0 for the theoretical.
RMS second year, team 12, 7 marks.
Right. Next team, 13.
BIMS Warriors.
Yes,
Pick
sir.
up.
Yes, sir.
Ankit ji, please pin and unpin team 12.
Shall I proceed?
Yes, sir.
Yes, sir.
Okay.
Ankit, please pin team 13.
Pin just.
Yeah, so there is an ear view and this lateral view.
Design mediastinal muscle. Question number one. So is a 28-year female provided with chest radiograph, a PA view and a lateral view showing a ill-defined radial opacity noted in the left hemithorax, and it is silhouetting with the left cardiac border. And on lateral view, it is seen in the anterior mediastinum, sir. It is located in the anterior mediastinum.
Okay.
So, and there is blunting of the left costophrenic angle.
Okay.
Taking into consideration of age and sex, anterior mediastinal lesion, sir.
Can be any anterior differential diagnosis of anterior mediastinal lesions can be considered, sir, in this case.
So name a few.
Sir, lymphoma.
Which is the most likely?
Sir, 28 years female, teratoma, then lymphoma, then
Thymoma.
thymoma.
Okay. The fourth T you forgot was terrible lymph nodes.
Lymph nodes, sir.
Okay. So well attempted on the X-ray. This is the CT.
On axial section CT, there are fat densities are seen within the lesion. So the probable diagnosis is teratoma, sir, in this case.
Fat densities.
Correct. So that answer is correct. I think you picked up all the findings. There's an anterior mediastinal mass lesion and there is pleural effusion. Would you need to further evaluate this? You think anything else should be required, a PET CT or something?
Sir, CT guided biopsy is required, sir.
Okay. Fine. So I think I can give them full marks.
Okay, sir. Okay, sir.
Team 13, Wims Warriors, 10 out of 10.
Yes.
Team 14.
Wildcard, please speak up.
Yes, sir.
Yes, sir.
Okay. So
Ankit, please spin.
So everyone speak clearly. So are you okay? Shall I proceed?
Yes, sir, we can start, sir.
Yeah. So this is a 47-year-old lady who has come with shortness of breath.
Bilateral fibrotic reticular opacities with subpleural splaining noted, sir, with apical gradient, likely NSAP.
So any differential? One more finding is there. I mean, you could do well to pick that up as well.
The esophagus is patulous.
Yeah, that is correct.
Yes,
So
sir.
I think your description and the findings are correct. Diagnosis is also correct. This is classical NSIP. You can never get a more classical NSIP. So my question is that in clinical aspects, what is the kind of importance you would give to distinguishing NSIP from other kinds of interstitial fibrosis?
Usually clinically, sir.
Yeah, I mean, what is the clinical, how does it affect the clinical outcome?
And UIP has a grave prognosis, sir. Usually the patient survives for 2 to 3 years, even if it's put on antifibrotics. NSIP, if you diagnose it properly and proper treatment is given, patient can survive well, sir.
Do you give antifibrotics to NSIP patients?
No, sir. Usually it's UIP, giving nintedanib or...
Yeah. So because if you identify classically, then, NSIP, you give steroids. And the patient
Yes,
shows
sir.
very good response, which is not the case with UIP, which you have to give antifibrotics, but that is also, I mean, it's questionable whether that has some effect or not. All right.
Yes, sir.
Yeah, what you picked up, well done. So full marks for the findings and the diagnosis and half marks for the question.
Okay. Dr. Nitin, half marks, can I give 1.5 or you want me to give 2?
2.
Okay.
Me plus
So-
1, plus 1. Only select slots are there, so let us stick to this. So plus 1 only.
Okay.
That will be total 8, ma'am.
Yes.
Yeah.
So wildcard, team 14, total 8.
So the last one, team 15.
Emerald.
Yeah, Emerald. Are you there, Emerald? Please shout
Please
out.
speak up.
Yes, sir. Yes, sir.
Ankit, please spin.
There are 3 people in this room.
It's only two, sir.
Okay. Okay, so your question and the last question for this quiz is 39-year-old female, shortness of breath.
HRCT axial section shows multiple opacities along the perilymphatic peribronchial regions with multiple subpleural cysts.
Multiple random nodules are noted within the in the periphyseal and subpleural area with multiple tiny nodules, and there is predominantly apical region is involved, and then likely I'll consider a differential of sarcoidosis in this patient.
What type of sarcoidosis? This is the question. Stage of sarcoidosis.
So I'm actually seeing paratracheal nodes in bilateral region with the lymph nodes, and with then there is a lung parenchymal involvement is there. So
Correct.
Stage 3 it will be there.
Yeah, that's absolutely correct. So my question is that if you ignore the lymph nodes, on what findings have you based your diagnosis on sarcoidosis? Why sarcoidosis? Why not UIP?
Because the involvement of the nodules are actually in the perilymphatic and the subpleural region, which will.
But what do you think about the interstitial thickening, traction, broncholectasis, some honeycombing as well?
Honeycombing is more in UAP rather than in sarcoidosis. Yeah.
No, that is not.
Cyst will be more in favor of. Appears the only cyst will be more in favor of UAP rather than whereas nodules in more in favor of sarcoidosis.
Okay, your description and diagnosis are correct. To the question I asked, the thing to be said was that, this is not showing an apicobasal gradient. All the fibrotic changes are predominant in the upper lobes. And when you find fibrotic lesions in the upper lobes, number one diagnosis should consider is sarcoidosis, even if I don't give you lymph nodes only picture. All right.
Yes, sir.
So full marks for the description and the diagnosis, half marks for the question.
Total of 8.
7.
7.
No. 7 for findings. Full marks for findings and diagnosis, so +7. And
Plus
for
1.
the question, it is half. That means +1 only.
Okay.
8 marks, correct.
8 marks. 8 marks.
Emerald team 15, 8 marks.
Okay, thank you, Dr. Sanjay, for the excellent session. And we come to the end of this round 1 for the chest radiology. And thank you very much.
Thank you.
We move on to the next round, that is the neuroradiology round. And Dr. Sapna, you can share your slides and team. We will start from team 15 now. So team 15 will continue. Just to randomize the questions, we will start in the reverse fashion now.
Ankit, please pin team 15 Emerald again.
Now we will go, Ankit, we are going from reverse order.
Okay. Dr. Nitin, just a second. I mean, my cases are in the order of the team. I thought it will be case 1 for team 1 and all the cases will show. I mean, let us have it again in the same manner, I feel. Let us have them from team 1 itself.
It doesn't matter, ma'am. We want to randomize things.
Okay, fine. So I'll show case 1 to team 15. That's okay. Fine. Fine.
It is team versus case, nothing else.
Yeah. So that's all. Yeah.
I can check according to the team, not according to the question number.
Yeah. So that's all right. Fine. That's absolutely all right then.
So pin team number 15. You're there.
Team Emerald, please speak up.
Their video should be pinned.
Yes. Ankit, please pin team 15 Emerald. Okay.
Yes.
Now we can start.
Yeah. Yes. So a very good evening, everyone, and thank you so much for giving me this opportunity, the organizing committee. And straight away, without wasting time, because there's paucity of time, I'm going to my case number 1, Now, case 1 is for a 3-year-old female who presented with headache and vomiting, and these are your MR images. Look at your images carefully. Each section needs to be seen. Start speaking something.
I've been provided with first image like MRI images of axial sections of brain. So initial section, I'm able to see the
retinal.
There is a hypodense lesion involving the eyeball, right eyeball. So in the posterior aspect of its likely from the retinal intra-orbital lesion is there. So and
this is okay. This is your axial T2 weighted, and these are all your post contrast images. And I would like to review you to review your axial T2 weighted image. Look at it carefully. Compare the right side with the left. Do you really feel there's a lesion sitting there, or would you like to review? And look at your post contrast images, and maybe then come back to your axial T2 weighted. Maybe it helps you. What are you seeing on your post-contrast images, team 15?
Post-contrast images, I'm seeing enhancement in the basal cistern area surrounding your cavernous sinus area.
Okay, okay.
And in the
post-contrast image of the spine? Any finding, or is it normal? Anything abnormal in your MR?
In the lumbar area, there is some abnormal enhancement in the intradural part of the lumbar area. Likely could be leptomeningeal metastasis could be a possibility.
Yeah. Now look at your axial T2 weighted image fast. Compare the right side with the left. 3-year-old.
Ma'am, time is over.
CSF metastasis is a possibility. With the drop metastasis from.
Ma'am, time is over.
Okay, so you were partly correct. Your description of the findings was correct. You did say there is enhancement that was seen in the basal cisterns and all. Are you able to see my laser pointer? So there was enhancement along the sylvian fissures, the basal cisterns, the tentorium, and you can see these nodular deposits. You can see these plaque-like deposits along the cortical surface. The nodular deposit, I think you did point out. You did talk of the leptomeningeal enhancement. So you were correct absolutely about the CSF seedlings. I told you to review your axial T2. Here you have a post-op eye. Don't you see? There's an enucleated eye out here and a 3-year-old. So this is a post-op case of retinoblastoma with CSF seedling. But I would like you to give marks for the description of the findings. So I think we can give them 2 on the findings.
And no marks for the diagnosis?
Diagnosis, I think you can give them 2 marks or something, because they were just close to this thing. I mean, rather than giving them a 0, because what they picked up was CSF seedlings correctly, and all the drop seedlings also they said, which were there, the nodular and plaque-like deposits. They were
so
only
plus 4 marks therefore. So an additional question.
Yeah, this you can answer. You can answer this. What is a trilateral retinoblastoma?
Trilateral is involvement of bilateral eyeball with the pineal gland, pineal blastoma. So
perfect. So they get full marks. 25 to 33% are bilateral, and when you have a pineal gland tumor, it becomes a trilateral retinoblastoma. So good, well done.
+7.
Yes,
+7.
+7. So now we come to the next team.
Team Emerald 15 +7.
And please pin up the team this thing.
Team 14 wild card. Please speak up.
Please get connected. Yeah, team 14, this is for you. A 40-year-old female presented with tingling and paresthesias, and these are the MR images. Your sagittal T1, your axial T2, and your post-contrast.
Yeah, there's an extra-axial lesion seen at the left CP angle cistern, extending through the left Michael's cave into the left paracellar region. It has T2 hyperintense areas in the center corresponding with the non-enhancing portions in the post-contrast images suggestive of necrosis. And this heterogeneous post-contrast enhancement in the post-con T1.
Yeah, you're correct. So, what do you think is your diagnosis? What do you
This
think
is
would
a
it be?
nerve sheath tumor. I think this is a schwannoma.
Of which nerve? When we say a schwannoma, we have to specify the nerve there.
Trigeminal.
Perfect, perfect, excellent. So the description is absolutely right. This is a dumbbell-shaped tumor, low signal on T1, high signal on T2, and you have this heterogeneous enhancement with cystic areas. You can see the cisternal component, you can see the component along the Meckel's tape and the waist at the porous trigeminus. Typical of a trigeminal schwannoma. Perfect. And the related question that I'm going to ask you is, name and association of the trigeminal schwannoma. Any association with trigeminal schwannoma?
Neurofibromatosis type 2.
Perfect. So they get full 10 marks. They are associated with type 2 neurofibromatosis. So can I have 10 marks, Dr. Nidhi, for this team, team 14?
Yes, ma'am. Yes, ma'am.
Next team is team 13. Team 13. Pin team 13.
Yes. So this is for team 13. 38-year-old male presented with headache and vomiting. And these are your MR images. A T1 weighted SASH. These are your T2 axial, your flare coronal, and this is your SWI, and these are your post-contrast images. Now,
T1, T2, and SWI and post-contrast images. And
yes.
on T2 weighted images, there is heterogeneous enhancement is noted in the left parietal region. This is an extra-axial mass, and there are evidence of blooming on SWI, suggestive of calcification, and it is
Calcification
or microhemorrhages.
Microhemorrhages. It's an extra-axial tumor located in the temporo-occipital region.
Okay.
And it's having a mass effect on the left cerebellar hemisphere and also temporal lobe.
Okay.
And it's showing a heterogeneous enhancement on post-contrast. So,
any other finding? Any other finding?
Ma'am, it is eroding the skull also.
Eroding, or would you like to see
There is hyperostosis of the skull.
anything else? Okay, okay. Chalo. What about your this thing? So, what about
Our
on the-
differentials? Differentials will be atypical meningioma and hemangiopericystoma.
Okay, very good. The only finding that you did not tell correctly was this is evidence of craniotomy. And can you see the small extracranial component? So yes, there is a dural base lesion. There are areas of hemorrhage. As you can see, it is showing intense enhancement. But the finding that you did not pick up was the craniotomy defect that you are seeing with the small extracranial component, indicating it is a recurrent tumor. And if you knew that it is a recurrent tumor, then obviously hemangiopericytoma would have been your first differential rather than an atypical meningitis. You're right. As far as that is concerned, this turned out to be a hemangiopericytoma. And the related question is that is it absolutely benign, or do these lesions metastasize?
Ma'am, metastasis.
Okay. Can you tell me the percentage? Just you have your points there. So anyway, this is a locally aggressive tumor, and about 10 to 30% of these lesions do metastasize, with the frequent sites being the lung, the liver, and the bone. So Dr. Nidhi, the findings were absolutely correct except for one finding of craniotomy. You can give them 2 on 3. Differentials were perfect, 5 on 5, and the answer was correct. They do metastasize. So that means they get how much? 8, I think. No, 9.
9 marks.
9 marks for this team. Very good. Well done. Next team.
Team 13, Wims Warrior, 9 marks.
Yeah. Okay. So they get 9
Team
marks.
12, RML second year, please speak up.
Yes.
Ankit,
Yeah.
please pin.
So, have they been pinned? No. I
Yes,
can't.
ma'am.
Just...
Yes, ma'am.
So the case for... Yeah, I can see them. The team 12, that is RML, a 2-year-old male presented with proptosis. And these are your CT sections here. Your bone window settings and your soft tissue CT settings.
In the soft tissue setting, we can see a soft tissue mass with
in the right orbital region, which is causing destruction, which is causing bony destruction and proptosis of the right eye.
There is newborn periosteal reaction.
Likely suggestive of an aggressive etiology, likely metastasis from
Sunburst pattern.
neuroblastoma.
The periosteal reaction is kind of sunburst pattern. With the history, first differential will be neuroblastoma.
Metastasis from neuroblastoma.
Very good. So you have these large extraosseous soft tissue masses associated with bony destruction. You can see them in the orbit, you can see them in the base of the skull. And this is the bony destruction as a characteristic sunburst, a periosteal reaction, which is known as a spiculated or sunburst periosteal reaction. So full marks on the description, full marks on the diagnosis. These are meds from the neuroblastoma. And this is your related question. What are the various radiographic findings or types of skull mets in neuroblastoma?
Sutural diastasis, sutural metastasis leading to sutural diastasis.
Yes.
Bony destruction causing sunburst appearance.
Okay.
What we just saw.
Raccoon eyes, periorbital ecchymosis.
Any other? So you're almost there. You can just have what I wanted to hear was they can just be in the form of just calvarial thickening that is there. They can just be lytic lesions also. They can just be dural masses, epidural masses, which enhance intensity. Yeah. So time over, you can give them around 9 marks. I mean, 1 or 2 things here or there, they get 9 marks. So maybe even 10 for that matter. That's up to the quiz masters to decide. I mean, the coordinator.
I think they are almost answered everything. So 10 is
Everything.
out.
They should get 10. They should get 10.
Okay, RML second year team 12, 10 marks.
Next is team?
Team 11.
Team 11.
Star Crusaders, please speak up.
Yes, sir.
Yes, so
Ankit,
this
please
is the
spin.
case for you. A 56-year-old male presented with headache and vomiting. These are your MR images.
Given MR images of T2-weighted image shows heterodense lesion in the occipital region with surrounding edema involved, which shows a heterogeneous enhancement, and there is also a pericallosal spread along the corpus callosum. And there are also enhancing lesions in the right paraventricular region and the right occipital region.
Look at the post contrast. Try to get some hint from the pattern of enhancement as to what type of lesion it is.
There is a heterogeneous enhancement. Shows heterogeneous enhancement with a central non-enhancing area. My differentials will be glioma and then lymphoma.
So on the enhancement, I want to hear, you said lymphoma. Do you want to qualify your enhancement? In the key descriptive findings, there needs to be a word which is helping you towards lymphoma. Anything you want to say?
North sign is present in the enhancement. There is a
differentials. You said GBM. You said
it's a lymphoma.
Which one would you want to put first?
GBM, because pericallosal spread is there.
Okay, so you're partly right. In fact, you had your differentials correct, but why it is lymphoma over GBM is what I wanted to hear is this typical ependymal enhancement that you are getting, and the subependymal spread. This is very, very characteristic. Crossing of the corpus callosum, both of them can cause with the restricted DWI. In a GBM, you will have more of hemorrhage, you will have more of necrosis, you will have more of
time is over. Time is over.
So CNS lymphoma over GBM. So that was the diagnosis. And your question is, what are the differentiating features with toxoplasmosis?
There will be eccentric target sign will be present in the pain pod sign will be present in the toxoplasmosis.
Two differentiating which are very important, which I want to hear.
The ring enhancement will be there in the toxoplasmosis, and there won't be pericallosal separate lesions will be
more important. MR spectro, tell me.
MR spectro, there will be a lactate peak in toxoplasmosis.
And lymphoma?
Lymphoma, there will be a lipid peak. Lipid peak.
Lymphoma will have a lipid peak or a choline peak because it's mitotic. Okay, so I think you can give them about the differentials 5 on 5 and key findings. I wanted to hear ependymal enhancement. You can give them 2 rather than 3, and even they answered the question.
The findings have only 2 marks, so we will give them 2 marks. And the diagnosis, since they have given GBM as the primary diagnosis instead of lymphoma, we should stick to 3 instead of 5. And
fine.
the answer that they have given is again
Partly
not
wrong.
partly wrong. Right. 1. Dr. Nitin, are you fine with that?
Yes.
So, ma'am, total of 7?
A total of 7, right. Only total of 6.
Total of 6. Star Crusaders, Team 11, 6.
Yeah.
Team 10. Mad Rats, please speak up.
Yes, sir. We are here.
Ankit, please pin. Ma'am, we can proceed.
So this is a 12-year-old male who presented with diabetes insipidus and visual deficits.
We can see in T1 sagittal section, we are seeing a T1 hypotenuse ill-defined mass, which is seen in the clival region and extending with cellular and paracellular supracellular extension.
Okay.
In post-contrast, it is showing a heterogeneous post-contrast enhancement. And we can also see the right-sided optic nerve sheath. It's not it's thickened the right side.
Thickened, or would you like to say something else? In case
infiltrated.
There is no perioptic CSF sheath is not seen, so it is likely infiltrated.
Yeah, encased by the lesion.
And in spinal sagittal section, we are seeing a dural enhancement in the post-contrast sequence. So this might be spread to the spinal region also.
Okay. Leptomeningeal spread is what
Yes,
you mean?
leptomeningeal spread is there.
Okay. So now 12-year-old diabetes insipidus, these findings, any differentials or any diagnosis?
I would like to have a differential diagnosis of pituitary. It's a pituitary craniopharyngioma.
Where is the epicenter?
Pituitary adenoma, yes. Or then I can keep second DD with, since it's involving clival region, clival cartomas can be selected as a long differential diagnosis. But the first we will say as pituitary adenomas. Craniopharyngioma kept as a second differential diagnosis.
No, you are not correct in your diagnosis. Your findings were still all right, but neither the pituitary adenoma nor the clival carcinoma cause any kind of leptomeningeal mets. These are not the tumors that cause. Craniopharyngioma also does not lead to any kind of this is not this thing list. So you're wrong in that. I'll tell you, this is an infiltrative lesion completely occupying your supracellular region, encasing your optic nerves, encasing the cavernosal segment.
Time is over.
Okay, heterogeneous enhancement, leptomeningeal spread. And I told you diabetes insipidus 12-year, this was a case of germinoma. So their findings are correct, but the diagnosis was not correct. So they don't get any marks for the differentials or the diagnosis. You can give them marks for the findings. And even they won't get marks for the related question, as I understand. So
only +2 marks.
Yeah.
Next is Team 9.
Mad Rats, Team 10 +2.
Yes. Next team.
Team 9, Star Wizards, please speak up.
Yes.
So which is the team now? Yeah.
Team 9, Star Wizards. Ma'am, we can move.
So this is a 59-year-old diabetic female who presented with high-grade fever and altered sensorium.
The given T2 axial section shows hyperintensity with loss of gray-white matter differentiation. And on contrast enhancement, there is a multiple ring enhancing lesions with pachymeningeal thickening. And on the top images, I'm not able to see the right middle cranial artery. So it might be right middle cranial artery occlusion causing ischemia, invasive fungal sinus, causing ischemia. And since there is a ring enhancing lesions in the right frontal lobe, tuberculoma, and there is an sinus, soft tissue thickening in the ethmoid sinus.
So
fungal.
Invasive fungal.
In case of fungal sinusitis with say intracranial spread.
Which fungal infection usually spread?
Mucormycosis.
Yes, absolutely correct. Your findings were correct. And this was a case of rhinocerebral mucormycosis with sinus infection extending here and a large MCA territory, in fact, with fungal abscesses out here. So description is correct and your diagnosis is correct. And the related question is, what is the black turbinate sign?
In T2 images in mucormycosis, there will be T2 hypointense of the turbinates
because of fungal
because of the fungal
invasion,
elements
and the invasion
and
of the
invasion.
No, this is not the correct answer. Actually,
Manganese deposition.
No. That is not the black terminate sign. That is a T2 hypointensity due to the paramagnetic metals is not what is. There is necrosis and devitalization of the tissue. So it doesn't enhance. And on the post-contrast images, it stands out absolutely black. That is a black turbinate sign. So you get, you don't get those 3 marks.
They get +7 because the answer was for this question was completely wrong.
Yes.
So +7.
Team 9
findings
Star
to-
Wizards +7.
Yes, findings to 5 diagnosis.
Team
and
8 now, team 8.
SMS Hospital, please speak up.
Yes, sir.
Ankit Pin.
So this is for SMS teammate, a newborn presented with seizures, and these are your images. Start speaking. You're running short of time.
Asymmetric prominence of temporal horn more than in right temporal horn more than left.
Okay, so I'll just tell you, don't waste your time on that. There was partial agenesis of the corpus callosum, and that was the reason. And obviously, I'm not showing you for partial agenesis. So please look at the images, try to pick up the finding for which I'm showing you the case. Look at this section. Anything abnormal?
Reduced Guerin sulcation, ma'am. There is lysencephaly spectrum.
Okay, but I'm trying to show you something here. Look at this image. Is this a normal section that comes at this level? Can you pick up something? Look at this. This is normal. See, look at the pons, look anterior to the pons. I cannot give you more hint than this.
Ma'am, there is some mass lesion anterior to the.
Yeah. So now fast.
Mass lesion
in the hypothalamic.
Signal characteristics of the mass lesion.
T2 ISO to slightly hyperintense mass.
Solid mass.
Solid mass, ma'am. Can it be a hypothalamic hematoma?
Hypothalamic glioma.
Glioma or some hematoma.
Yeah. So basically, you have to see this ISO intensity to the gray matter on all imaging pulse sequences, which is
time is over.
So it's a hypothalamic hematoma. In fact, that is the answer. The differentials were correct, but your answer is not correct, and your findings were almost. I gave you the clue. So in the findings, they get 1 mark, and they can get 2 marks on the differential diagnosis. It was actually very, very typical of a hypothalamic hematoma and not glioma. That is what you were to see, pick on these MR images, that it is absolutely ISO intense to the gray matter on all your imaging pulse sequences. And do I ask them the related question or not? They were partly correct in their differential.
You can ask. You can ask.
Okay. So the question is, what is the classical clinical presentation of the hypothesis?
The newborn will present with elastic season.
And precocious puberty. These are the 2 classical clinical presentations.
They get total of +5 marks.
No, no, sir, they answered only 1 point out of the 2 points that ma'am asked.
So that's why only +1 and +4 from the previous. So +5 total.
Okay.
But ma'am told 2 for diagnosis. It will be 3 for the diagnosis?
It is +3 for diagnosis, no option for +2.
Okay.
Okay, fine. Next.
SMS hospital team 8, 5 marks, huh?
Yes.
Plus
Yes.
5.
Yeah.
Team
Team
7.
7 now. Team 7.
Yes, sir.
Team Barnard, please speak up.
Yes, sir. Yes, sir.
Okay. So this
Ankit,
is for
unpin and
you.
pin.
A 9-year-old female presented with episodes of meningitis following trauma.
Trauma episodes of meningitis. I am provided with serial MR sequences of a 9-year-old male, female patient.
Okay.
On T2-weighted imaging, I can see sinusitis involving the left-sided all sinuses, ethmoid, sphenoid sinuses, T2 hyperintensity noted. On serial axial sections of brain, I can see using T2 hyperintensity is noted in bilateral, bifrontal, basifrontal region, and in bilateral frontal regions. And on a flare, they are suppressing current episodes of meningitis following trauma.
Recurrent episodes of meningitis.
Yes, ma'am. So possibly we are going for a flare. The hyperintensity are getting suppressed. So on the cis sequence, we can see again hyperintensity. So probably there is a CSF rhinorrhea following trauma. There could be a cribriform plate fracture with
Only
CSF.
rhinorrhea, or would you like to further see? What about this?
There is also brain, left-sided brain parenchyma seems to be herniating through the defect.
And there is another very important finding that you need to pick up. Apart from this herniating brain,
Yes, ma'am.
anything that strikes your eye, look at this image.
Bilateral cavernous sinus or flow voids are noted, ma'am.
Okay. So now your diagnosis?
Also carotid cavernous fistula enlarged.
With
Bilateral superior ophthalmic veins are enlarged. So with
Okay.
the herniation of with the brain anterior cephalocele herniation with an CSF rhinorrhea, cribriform plate fracture.
Yeah. So it was a frontoethmoidal encephalocele.
And time is over.
With bilateral CCF. So they were right in the description of their findings as well as the diagnosis. And here you can see beautifully the communication between the intracavernosal segment and your cavernous sinuses. And the related question is, what type of CCF fistula is there in this case?
We use Barrow's classification, ma'am.
Okay.
So we
So
have
this is
4 types, and this is
type
direct fistula type 1.
Type A, we call it
Type A,
ABCD.
type A. Yes, ma'am.
So they get full marks for the related question also. So it's type A CCF. They were
Plus
correct.
10.
10.
Plus 10.
Yes.
Team
Plus 10.
Barnard,
Plus 10.
Team 7, Barnard, 10.
So next is Team 6. Team 6.
Mantri, please speak up.
Yes, sir.
Okay. So this is for you. A 4-year-old presented with gradually progressive loss of vision in bilateral eyes. And with this history in mind, please look at these images. A gradually progressive loss of vision in bilateral eyes.
Sir, ma'am, there are T2 hyperintensities which are noted in bilateral bilateral thalamus and extending to midbrain. Optic nerve and optic chiasm here. Also in optic chiasm location, likely
Okay.
optic nerve.
What else?
If you T2 hyperintensities are also in the ethmoid, bilateral ethmoid hair cell, maybe
So I said loss of vision. When you have loss of vision.
optic nerve gliomas.
Yes, but your diagnosis is correct, but the description of findings actually is a little incomplete. You won't get full marks for the description. You had to describe this optic nerve enlargement, intracanalicular extension, prechiasmatic extension, optic chiasma being involved, and your retrochiasmatic pathway. Okay. And when you have, so you get your marks for the diagnosis of bilateral visual pathway gliomas, but not full marks for your key imaging findings. Okay. And so, and it is pathognomonic of which condition if you get bilateral optic gliomas?
NF1.
Okay. And the related question that I was to ask you is, what are the differentiating features of optic glioma with optic sheath meningioma? How do you differentiate?
Tram track sign.
What does that mean?
Ma'am, seen in meningioma. Ma'am.
Yeah. What does it mean when I say tram track? You need to have a meaning to your science, na?
Peripheral enhancement of the nerve sheath. It's the circumferential or peripheral enhancement of the nerve which is noted in the axial images.
Basically, then you can see the nerve separate from the lesion. Okay, through the lesion, and it's separate from it. So that is a tram track or a donut appearance, that your nerve is seen separate. Any other more point of difference? Only one is that you can see your nerve separate. In glioma, you cannot see your nerve separate. Any other point to get the marks?
Nerve enhancement in case of optic gliomas. The entire nerve enhancement.
No, you are not correct in your answers. Meningiomas, they enhance much more intensely as compared to optic gliomas, which do not enhance much. And your nerve is seen separate, what is known as a donut appearance or a tram track appearance. Okay, when you can see the nerve like this separate. And of course, the fact that you can see calcification and the middle-aged women and all, these would have been the other points of difference. So they get some marks for the key imaging findings. Diagnosis, they were bang on. Optic gliomas.
So they only lose 1 mark. They only lose 1 mark. So +9, I guess.
Sir, but they didn't answer the theoretical question right. So they
Okay.
will only get 1 mark for the findings, 5 marks for the diagnosis, and 0 marks for the theoretical question, right?
They were not able to answer the
7 marks, na +7.
Yes,
So
plus
6.
plus 7, maybe 2 marks for the imaging findings is what you are
2
giving.
marks are the total marks for the imaging findings, but they told partially the imaging findings, as you said.
Yes.
So we are giving 1 mark. Is that right?
5 for the diagnosis, and
Yes, ma'am.
whatever marks should be half for the key imaging findings.
So
6
that's why
marks,
plus
total 6 marks.
plus +7.
Sir,
Team
partial
6,
marks
then
है
1
ना
3.
diagnosis. Sir, 6 होंगे इनके. Let's be
नहीं
clear
नहीं
about that.
diagnosis was correct na.
So diagnosis is 5 and 1 for
हाँ.
the description, so it will be 6.
And +1 for the partially correct answer.
Achha, that was
Tram,
that
they
means
told one tram track sign, which helps to differentiate, but they were not able to clearly tell what it means. So
So you want to give them marks or no marks for the
give
answer?
them 1 mark maybe for that tram track sign. Yes, you get in a meningioma. They were
So
correct.
that's why +7.
Okay.
Okay. Then 1 3 6 plus 7. Team 5.
Team 5.
Guatemalan Hospital. Speak up.
Yes, sir. Yes, sir.
Yes, here is the question. 45-year-old HIV seropositive presented with high-grade fever, seizures, and a state of confusion. And these are your remarks.
Sir, I'm presented with axial T2 bipolar coronal flare and post-contrast images, which is showing multiple bilateral T2 hyperintense lesions in the periventricular basal ganglia and deep white matter, which is showing ring enhancement in post-contrast sequences.
Okay.
Most likely differentials under clinical setting of HIV would be toxoplasmosis.
Okay, and one very important finding, imaging finding that I put, you haven't mentioned that imaging finding. HIV seropositive and ring enhancing, you were right, Toxo, but what is the finding that I want to hear in these images? Very important, and it's
bilateral parietal white matter hyperintensities.
That is the edema, perilesional edema. Can you pick up that finding?
With ring enhancing lesions in gray white matter junction.
That your gray white matter junction or corticomedullary, yes, and any other very important finding that is almost virtually diagnostic of toxoplasma.
Open ring towards the
directly diagnostic awareness of toxoplasmosis.
See, you are getting this eccentric target sign, and this, if you see this eccentrically enhancing nodule or the eccentric, that's virtually diagnostic. The other you did say corticomedullary junction, predilection for the basal ganglia, predilection for the thalami. So basically your diagnosis was correct, but you will not get full marks for your key imaging finding. I wanted to hear this eccentric target sign, which I've put up specifically.
We told ring enhancing, ma'am.
Ma'am, time is over.
So eccentric target is very, very diagnostic of ring enhancement. You can get in 101 lesions, but this is virtually diagnostic of toxoplasmosis. So,
Okay.
okay, and this was after the treatment, the lesions resolved. So it was indeed a case of toxoplasmosis. And your related question is this: what will be the imaging findings in the commonest fungal infection in an HIV seropositive patient? First, tell me which fungal infection is there in HIV seropositive. The commonest fungal infection that you get in an HIV seropositive is cryptococcal infection. And I've asked you the imaging findings. Tell me.
Bilateral mucinous, it will be similar to CSF intensity, cystic, small cystic lesions.
Any name?
Basal.
Which it will be same to which of the some space similar to
Enlarged Virchow Robin space with the mucin material filling them in the bilateral basal ganglia.
Okay. Any other? Okay, so we can give them marks, Dr. Nidhi. They were not completely right in the description of their findings. Yes, and the diagnosis was correct, so you can give them full marks on them. And the imaging findings were partly correct. They did talk of the dilated Virchow Robin spaces, but not the gelatinous pseudocysts. They did mention the cryptococomas or the parenchymal lesions. So you can decide accordingly. Maybe
So, 7 marks total, 1 for the
imaging findings
and 5 for the diagnosis, and 1 for the theoretical answer.
Yes, yes.
7 plus 7.
Okay. Vada Malayan team 5 plus 7. Team
Next
4,
is team
Charaka,
4.
please speak.
Team 4.
Yes, we have unmuted, sir.
Yeah. This is the case for you. A 24-year-old presented with gradually progressive swelling along the right side of the face.
So on base images, on T2, we see a heterogeneous T2 hyperintense transspatial lesion with multiple cystic spaces that are noted within it. The lesion is almost iso-intense on T1 images. And this is again T2.
Okay.
Take a minute. So, ma'am, based on the
Please describe the findings. There's a very important finding that you have not.
Target.
Very important finding out here. I need to listen to that before you come to the diagnosis. Look at your images carefully.
Target. बीच में कहाँ ये बता नहीं दिख रहा
Okay, now what is the diagnosis? I don't think you are able to pick up that finding.
Ma'am, most probably this is a plexiform neurofibroma because there is target sign seen in some. There is central hypo intensity seen in the.
Okay, so you are correct about the diagnosis. Still, I'll tell you there's a very important finding which is there. You want to? The time is still there, Dr. Nidhi.
Right globe.
Ma'am, 20 seconds.
Okay, just pick up that findings, then you'll get your full marks for the findings.
The central dot is there, ma'am. Mostly.
You have already spoken of that.
Appearance is there in some of the.
Okay, wait. Yes, there is an infiltrative soft tissue. Yeah, tell me.
And bone. Yes, ma'am. Bone. And ma'am, there is some lysis of the bone.
Ma'am, time is
underlying
over.
bone
Time
seen,
is over. Time is over.
Pressure
effect on the bone.
Effect is seen on the bone, ma'am. Yes. So because of the pressure effect,
no, you are not. There is dysplasia.
And there is extension.
Plexiform neurofibroma. This will be dysplasia of the greater wing of the sphenoid bone. This corroborates the fact that it is a case of NF1 with a large plexiform neurofibroma. So the key findings, some marks will be lost, but yes, your diagnosis is correct. It is indeed this dysplasia of the greater wing of the sphenoid is what you missed in your description. And the related question is there a risk of malignant transformation in these lesions, or are they completely benign lesions arising from the peripheral nerves?
Yes, ma'am. There is a transformation. Malignant. Ma'am, the audio.
There is a chance of malignant transformation into malignant
Yes,
peripheral nerve
so you are
tumors,
correct.
ma'am.
They can transform into a neurofibrosarcoma. So that is there. They are not completely benign, and they really need to be followed up and resected. Okay. So Dr. Nidhi, 5 marks for the diagnosis,
Yes, ma'am.
and they missed up the dysplasia was missed, and the answer to the correct question was correct.
So description, half marks?
Yeah. So the total, I think 9 marks would
9.
be all.
Yes, ma'am. 9.
Is
9
all right.
marks.
Yes.
That's exactly what is coming.
Charaka team 4, 9 marks.
Team 3.
Team 3, take it odds. Please speak up.
Yes, sir.
So this is has the team 3 is there, 6-year-old male who presented with seizures.
Okay. Finding. Sir, there are multiple hypointense nodular lesions in the subependymal regions, subependymal nodules.
Okay.
My diagnosis is tuberous sclerosis. There's evidence of cortical tubers in the frontal region,
Okay.
bilateral frontal region, and where in the parietal regions also on the right side.
Absolutely correct. Multiple cortical tubers and the subependymal nodules have been rightly picked up. They are enhancing. You can see them on T1. So very, very typical of tuberous sclerosis. And you picked up both your cortical tubers and subependymal nodules. So that's correct. And the related question for you is, what are the imaging findings of the brain tumor that is associated with tuberous sclerosis?
The brain tumor that is associated with cerebellar.
Team 3?
Sega is the there can be malignant transformation of the submental nodule also. It's located in the at the foramen of Monroe. It's subependymal giant cell astrocytoma. It shows heterogeneous enhancement. It shows enhancement, heterogeneous enhancement.
Okay, so you are correct. The subependymal giant cell astrocytoma is situated at the foramen of Monroe and it enhances intensely. So they get their full marks. Okay, for
10
so
marks.
the next team. Full marks for team 3.
Team 3, take it odds, 10 marks.
Yes.
Team 2, fantastic duo. Please speak up.
Yes, sir.
Yeah. So this is for you. A 1-year-old child presented to the emergency department with high-grade fever, difficulty in breathing and difficulty in swallowing. Yeah, unmute yourself, team 2, please unmute.
There's CT axial neck, diffuse. There's diffuse soft tissue swelling noted in the retropharyngeal and prevertebral region with rim enhancing and with central hypodense areas, and on post contrast area I could see contrast enhancement in the central aspect, and this is causing narrowing of the pharynx anteriorly, and the lesion is spreading towards the right posterior cervical space.
Please speak loudly. I can't really understand you. Yeah.
CT axial neck showing soft tissue swelling in the retropharyngeal and prevertebral region with peripheral hyperdensity and central hypodense lesions, and on post contrast enhancement there is heterogeneous contrast enhancement with with central enhancement. Anterior it is causing compression of the nasopharynx, and posterior and lateral it is spreading to the posterior cervical spine. It looks like a retropharyngeal abscess. Different possible diagnosis is retropharyngeal abscess.
So the
Causing,
key findings are correct, but your diagnosis, retropharyngeal abscess, would you like to add something to it? Look again at all the images.
What is this here? I think peritonsillar abscess.
Retropharyngeal abscess is correct, but you want to add something, and you have described it also.
With a paravertebral extension.
Time is over.
Okay, so they have described the retropharyngeal abscess, but they haven't really talked about the pseudoaneurysm, though they did talk about the contrast enhancement. So it is actually partly correct, retropharyngeal abscess, but there is a pseudoaneurysm formation, your non-contrast and your contrast enhanced scan. So they're partly correct, so I can ask them
+5.
question.
+5.
Okay. So what do you see on color Doppler in a pseudoaneurysm?
Yin-yang sign.
What is that?
Both to and fro color movements are seen with the red and blue color, which indicates to and fro flow because of the swirling movement in the pseudoaneurysm that gives appearance of yin-yang ball.
Okay, but why does this swirling motion happen? That's what I'm trying to ask you.
Turbulent flow because of neck being narrow neck. Because pseudoaneurysm has a narrow stalk and aneurysmal structure, and there's only one way motion. There's no it swirls to and fro.
Okay, so your sign is correct, but basically it fills up in the systole and the blood moves out during Dashley. Narrow neck you may have in a true aneurysm also, but still you do not get a yin-yang sign. Okay, so basically you're partly correct in the related question also, and partly correct in your key description, but your diagnosis, you missed the pseudoaneurysm. In fact,
5 + 1 6. 5 + 1 6.
Yeah.
Fantastic duo. 2 6 marks.
Okay, team 1 now. Team 1.
X-ray, please speak up.
Yes, sir.
Yeah. So a 34-year-old presented with progressive loss of vision in the bilateral eyes, and these are the MR images.
So there is abnormal thickening of bilateral optic nerves with loss of perineal CSF sheath, CSF space. Along with there is enhancement. There is also apparent thickening of bilateral trigeminal nerves.
Thickening of?
Bilateral trigeminal nerves.
Okay, and your next set of images? MR images of the spine and one through the abdomen, through the kidneys. Here?
The multiple hypointense round-shaped lesions located within bilateral kidneys.
Describe. You said thickening of optic nerves. You said
There is
thickening of
thickening of all the
nerves.
all the nerves in the cervical spine throughout the exiting nerves are thickened in the cervical neural foramina. Features are sensitive of multiple schwannomas.
Kidneys, anything you want to add?
In the kidneys, we can see multiple round shaped T2 hypointense structures, which might represent pain and multiple angiomyolipoma.
So in the kidneys, what are you saying? They are?
Multiple angiomyolipomas, multiple cysts.
Multiple cysts. This is a contrast enhanced CT. Oh, MR, contrast enhanced MR. So you have described
regions. Multiple non-enhancing regions are noted with regions.
What is your diagnosis?
Neurofibromatosis. Neurofibromatosis 2 because of multiple schwannomas
and kidneys. Why would I have put a section of the kidneys? For cysts, you are saying. Are they cysts?
Ma'am, time is over.
Hypointense regions. Adrenal
You did pick up the bilateral thickening of the optic nerves. You did pick up the thickening of the trigeminal nerve. There is infundibular thickening as well. There is some infiltration in the Meckel's cave, and these are thickening. You talked of the thickening there, and here you are making them lesions. These are basically cervical and your dorsal nerves.
Nerve thickening.
And that are intensely enhancing thickening of multiple cranial and spinal nerves along with these deposits in the kidneys. So your diagnosis is not schwannomas and NF, but this is a case of CNS lymphoma and secondary to systemic involvement. So this is a case of secondary CNS lymphoma. Please remember, whenever you get thickening of multiple cranial nerves, thickening of multiple spinal nerves, always have CNS lymphoma in your mind. And so your findings were correct. So I think I can ask them this related question. What are the various ocular manifestations of lymphoma on imaging?
There can be hyperenhancing optic nerves. There can be chloroma, thickening of the optic nerves, causing visual impairment as a clinical sign.
So you're partly correct. You may get thickening of optic nerves. Chloromas you get typically in leukemias. Lymphomas, chloromas, they are deposits that are in the extracorneal compartment of the orbits, and you may get what you said, bilateral gland enlargement. That is very, very characteristic of lymphomas. Okay? So, I mean, partly correct on the description of their findings was correct. They picked up all the findings except for the kidney thing, but they diagnosed, they were absolutely off the diagnosis. So they don't get any, they did not entertain it in their differential also. And
Plus, so
Plus two
total
for
of
the findings.
plus one findings was this related question was partly correct.
Yes.
Okay, so
So
how many
plus
marks were
3.
related?
2 plus 1, 3.
Plus 3.
Okay.
Yes, 3.
X-ray team 1 plus 3.
Yes.
So we come to the end of this round 2, and thanks to Dr. Sapna ma'am for the excellent session, and it was quite educative as well for all the residents who attended this session. And thank you very much, ma'am.
Thank you, Sapna ma'am. Thank you, ma'am.
Thank you.
So we move to round 3 and abdominal imaging. First 8 teams will be covered by Dr. Sharad. Dr. Sharad Maheshwari, you.
Dr. Nitin, you want me to tell the scores before we
Yes,
start
yes.
it?
Before that, Dr. Sharad, we will just start, and Dr. Nidhi is going to announce the cumulative scores till now after the end of round 2.
Team 1, the scores are total for the 2 rounds. It is 3. 0 for first round and 3 for the second round. Team 2, 1 plus 6, total 7. Team 3, 7 plus 10, total 17. Team 4, 10 plus 9, total 19. Team 5, 0 plus 7, total 7. Team 6, 1 plus 7, total 8. Team 7, Team Bernard, 9 plus 10, 19. SMS Hospital, 0 in the first round, 5 in the second round, total of 5. Star Wizards, 10 in the first round, 7 in the second round, 17. Madreds, 10 in the first round, 2 in the second round, 12. Star Crusaders, 7 in the first round, 6 in the second round, total 13. RML, 7 in the first round, 10 in the second round, total 17. 13, team 10 in the first round and 9 in the second round, total 19. Team 14, 8 in the first round, 10 in the second round, total 18. 15th team, Amarillat, is 8 in the first round, 7 in the second, total 15.
Yes.
Sir,
Thank
please
you very
make the screen full. Questions are being visible.
Yeah, Dr. Sharad, you can start, and team 1 to face the question. So
Yes,
pin the team 1, and Dr. Sharad can start. You have to set the slideshow format. Yes. Dr.
One
Sharad.
X-ray, please speak up.
good
One X-ray.
Yes, sir.
Team 1.
Ankit, please pin. Team 1.
Yeah, so good evening, everyone. So what I have done is all the questions I have already sent, and each question has marking. So like if you give a differential diagnosis, there is a marking. If you give a diagnosis, then there might be a question on management. If you give that question answer, then also you get marking. So just diagnosis might be just 30-40% of marking. And since it's online, I understand. So I've kept only one slide of images and they have been labeled. So we have a case 1, is a 79-year-old male who presented to emergency with severe abdominal pain. never had any imaging, but on checking with history, hepatitis C positive was known. So there is a set of CT scan images. The phases have already been labeled.
There are multiple hypodense lesions which are taking peripheral contrast enhancement on atrial phase and on the early washout of the levels of contour, nodular liver contour is there, and capsular retraction is there. The differentials can be malignancy, hepatocellular carcinoma, early washout is there, early enhancement and early washout.
Team 1, please speak loudly.
Early enhancement and early washout of the lesion is there. The differential are hepatocellular carcinoma as the first
No, so
differential
we'll come on the findings one by one. If you tell me what is the primary diagnosis?
Hepatocellular carcinoma with capsular retraction in a cirrhotic
How's the
liver.
liver?
Cirrhotic.
So liver cirrhosis, HCC. Okay. What else? Why did this patient have abdominal pain?
There is rupture of one of the lesions.
Right. So
resulting in hemorrhage, peritoneal hemorrhage.
what is your full diagnosis?
Hepatocellular cirrhosis with hepatocellular carcinoma along with rupture of one of the lesions.
Hemoperitoneum.
Yes.
What is the management?
Exploratory laparoscopy, surgical management.
No, so the patient is bleeding right now, and if you go for surgery, and then there will be a lot of complications. There is an easier way of treating. Yeah, so you do embolization, and if possible, do TACE itself on the same sitting, but not necessarily.
Dr. Sharad, time is over.
Yeah. So Dr. Nidhi can do the marking.
Okay. So
I had to do a lot of prompting for them to give the right.
Okay. So I think their description was partially correct and diagnosis was completely correct, and answer to the question was on after the clue only. So they get
8.
7 plus 7 marks.
Plus 7. Team 1, X-ray.
Okay. So just quickly summarize liver cirrhosis with ruptured HCC, extravasation of contrast and hemorrhagic ascites. So you should have told the extravasation thing. Cirrhosis get 2 marks, HCC 2 marks, bleeding 2 marks, ascites 2 marks, management 2 marks. Okay. So this is real history, but it is little weird and nothing to do with the diagnosis. So there was a patient who,
Next is team 2.
Yeah.
It's fantastic. You please speak up.
Yes, sir. Yes, sir.
Okay. Next question to team 2.
Yeah. So this patient came to us for renal mass evaluations, but this case has nothing to do with renal mass for the images I'm showing. So first describe me what images are seen and then give your findings.
There is moderate hepatomegaly and massive splenomegaly on NECT scans, and on MRI T1 and T1 T2 weighted images are showing diffuse hypointensity of T1. Both liver and spleen are both liver and spleen are hypointense on T1. I cannot see pancreas image or these are hypointense with respect to the paraspinal and the abdominal muscles. So
but hypointense on which sequence you said?
What is it? T2 and T1.
Okay, so and what is the finding on CT?
CT, massive splenomegaly and moderate hepatosplenomegaly with.
No, that is not enough because there is something more.
Multiple lymph nodes.
calcified, no, but the liver and spleen are very dense.
Or
They are
hyperdense,
hyperdense.
or on plain CT they are very hyperdense and
So they are
not
hyperdense.
at hepatocyte
Okay,
one screen
now,
majorly. And first differential diagnosis is
okay.
Hemochromatosis.
Okay. That's an easy diagnosis. But now tell me which is which, the two T1 sequences, which are these sequences?
In phase and in phase and opposed phase.
So which is in phase, which is opposed phase?
Second one is two phase in phase, and the third image is opposed phase.
Oh, so if you see that India Inc. artifact around the organs,
No,
so this
out
is
of
the
phase.
out
Sorry.
phase. Now what happens? In fatty liver, there is a signal drop on the
Sir, time is
out
over.
phase,
Dr.
but
Sir, time
it
is over.
reverses on fine. So I think you got this iron overload right. Sequence you got wrong, and you didn't tell the hyperdensity.
So they get +7.
Yeah, that's fine.
Next is team 3.
Yes, sir.
Okay. So this is a 75-year-old gentleman who presented with abdominal pain and fever. So all our CT images, they are labeled.
There's gallbladder wall thickening with enhancement noted on the arterial and portal venous phases. CBD is dilated, and there's thickening of the CBD wall also.
Pericholecystic fluid is seen.
It's pericholecystic.
Okay, so what kind of thickening it is?
Hypodensity. Circumferential. The circumferential.
It's like diffuse.
Thickening.
It's diffuse thickness. It is not focal.
Diffuse
Number one, it is diffuse thickness. And how is the lumen of the
enhancing wall
gallbladder?
thickening.
And how is the lumen of the gallbladder?
Collapsed, sir. It's
a bit of contracted.
Contracted.
There's no fluid actually. You don't see the fluid, but
No
maybe
fluid.
there is where in these images you don't see the fluid.
Hypodensity of the surrounding liver.
So this is a gallbladder which is partly contracted, and there is diffuse wall thickening. Now all the clue are in the wall, and so with the diagnosis and differential diagnosis.
Diagnosis gallbladder CA gallbladder, sir.
Okay, and differential.
So differential can be an inflammatory cholecystitis, like
chronic cholecystitis.
Can you give a better term for that inflammatory
xanthogranulomatous cholecystitis can also present in the same way.
No, so means obviously it's a tie between gallbladder cancer and inflammatory thing. So the key features are if you see the lumen is contracted.
The time is over.
Lumen is contracted.
And the thickening is diffuse. It is very hypo in the wall.
Tissue
So this
planes
was
with the surrounding liver.
so this was a xanthogranulomatous cholecystitis.
So the next question.
Yeah.
Next question, sir.
Diffusely infiltrating cholangiocarcinoma can be a
differential.
So the time is over.
Diffusely infiltrating.
Yeah. So this was a xanthogranulomatous cholecystitis.
So the distribution of marks they have.
So I think
the findings.
They'll give we'll give half marks, 5 meaning.
We can give
5 or 6.
the
You can give
findings.
6 you can give.
Okay.
Actually, total of +6.
So we will give 2 for the findings, 3 for the partial diagnosis, and 1 for the theoretical answer, right?
Right.
Diagnosis. Both the diagnosis.
We said both the diagnosis.
No. Because see, in the differential diagnosis, you didn't give xanthogranulomatous cholecystitis. I had to prompt you and tell you.
Xanthogranulomatous cholecystitis.
We had said xanthogranulomatous cholecystitis.
You just said inflammatory cholecystitis. So we wanted more specific.
So
This doesn't.
Full marks will be given only when it comes without any clue.
I did a lot of prompting. Yeah. Okay. So case 4.
Total is 6. Take it odds.
Yes.
Team 4, Charaka. Please speak up.
Yes, sir.
Yes, sir. So 44 female presented with epigastric pain. So straight away, I'll show the MR images.
So on the MRCP, sir, what we see is a saccular outpouching from the common bile duct, which is seen, and this outpouching is in communication with the common bile duct. The gallbladder is not seen separately. The rest of the visualized intrahepatic biliary radicals are normal. The distal CBD is normal in caliber, and so is the visualized MPD, sir. So based on the imaging findings, sir, our diagnosis would be a choledochal cyst. And because it's a diverticular outpouching, sir, we would think about a type 2 choledochal cyst in this particular case.
Any part of the bile duct which is dilated?
Yes, sir. The common hepatic duct is dilated right here, sir. Although the right and the left hepatic ducts appear normal, the common hepatic duct appears dilated and prominent. The intrahepatic radicals are not dilated. Yes, sir.
So what is your diagnosis?
This would be a type 2
choledochal
choledochal cyst.
What are the complications?
The complications of choledochal cyst would include
cholangiocarcinoma is Caroli's disease, sir. Over other complications can be a
stone
calculi formation.
Primary CBD calculus can form. Sir?
Right. So complications, you're right. Choledochal cyst, you are right. But here the main involvement is in the common duct and the cystic duct. So actually, now it is called as a type 6 choledochal cyst, though it is not widely accepted, because in the previous Todani classification, there is no mention
time
of.
is over.
Yeah, the cystic duct. So I think
findings was all right, diagnosis was fine, and the response to the question was also correct. So +10.
No. I won't give +10 because they did not say it is a cystic duct. 7 or 8, not more than that.
Okay. So
We will give 1 for the findings because they missed one important finding, and give 2 for the theoretical ones. Will that be fine?
Yeah.
So 5, 3, 8.
8.
Charaka team 4, 8. Charaka team 4, 8. Now team 5, Vada Malyan Hospital. Speak up.
Yes, sir.
Vada Malyan Hospital.
Yes, sir.
Ankit, please pin unpin.
Okay. So we have a 45-year-old female who had recurrent history of urinary tract infection. We have ultrasound and 1 CT image.
Dependent.
You are provided with ultrasound and non-contrast CT abdomen images, which shows multiple anechoic cystic lesions with dependent debris and a few calcific foci in the dependent region in the right kidney. Kidney appears enlarged. In CT, non-contrast CT, which is showing this looking like a calyceal dilatation with the pelvis wall thickening, renal pelvis, right renal wall thickening, and wall calcification. So considering this pelvicalyceal dilatation, diagnosis could be renal tuberculosis. First differential diagnosis. With the second differentials could be xanthogranulomatosis pyelonephritis with secondary to chronic infection.
Any radiological sign?
Beer passing, blunted calyces.
Yeah. So this is the marking.
Sir, you want to
Time is
ask any
over.
secondary question?
No, that's fine.
Okay.
So
Nitin sir,
they will score total marks 10 out of 10
10 out of 10?
because they have told.
First diagnose tuberculosis versus xantho.
Granulomatous pyelonephritis.
So they initially mentioned tuberculosis.
So maybe 8 or 9.
So they will get +8 marks.
The 9 solo correct.
Okay, team 5, Vadamalayan Hospital, +8. Team 6, Dhanvantri, please speak up.
Sir, yes, sir.
So you can move ahead. Next
So,
question. Yes.
6-year, elderly gentleman with left flank pain, known chronic kidney disease. So here you have ultrasound and MRI. MRI have been labeled. So describe me properly.
Sir, on USG of the left kidney shows there is a hyperechoic lesion which is noted in the interpolar region of left kidney. Then in non-NSCT,
Doppler, you didn't mention Doppler.
yes, sir, there is no intra-lesional vascularity which is noted. And on the second image shows there is a
It's a T2 by mistake. It's
yes, sir,
NEC.
yes, sir. Hypointense lesion, which is noted. The lesion appears hypointense. Then again, the T1 weighted fat set images shows there is a iso-intense lesion, and on diffusion weighted images at b-value of 800 shows restriction of diffusion, which appears as hypo on ADC images. So the differential can be.
But there is one more image.
Yes, sir. ADC at a different level. There are no areas of restriction of diffusion which are noted, sir. However, shine through can be seen, sir. T2 ADC hyper intensities. So this can very well be some abscess, sir. The first differential can be abscess. Other restriction of diffusion again lymphoma can be another differential for the lesion, sir. And bilateral kidney are small, and there is perinephric fat extending, likely secondary to CKD.
So you are saying abscess. What else?
Sir, and there is
how is the appearance on ultrasound?
Sir, ultrasound appearance is slightly hyperechoic, sir.
Or fluid or solid?
Dr. Shah, the time is over for this team.
Okay. So this finding you missed. This you see
yes,
restricted diffusion in the
diffusion within the renal vein.
Yeah, so it's a difficult image. I'm sorry for that. So tragic cyst, RCC, abscess. On surgery, it was a solid cystic RCC eosinophilic type. Key finding was 1, solid appearance on ultrasound. 2 was restricted diffusion in the mass and the left renal vein. So I think this you have missed, and you didn't say RCC in differential, no?
Sir, solid appearance can be, sir, Fox, because, sir, there was no vascularity within the lesion, sir. So it was likely difficult on USG, sir.
With restricted diffusion, and
Sir,
because hemorrhage can show restricted diffusion, but then the ultrasound appearance was not hemorrhagic. So you should keep RCC as a differential. You get for abscess, you get for ultrasound appearance, you get for restricted diffusion in the mass. So maybe 6.
+6, +5, +1, +6.
Dhanvantri, team 6 +6.
So we are
Okay,
giving
next is
them
team
half
7.
marks for diagnosis. Half marks for diagnosis.
Yeah.
50% marks for diagnosis.
So
right?
+6 is the marks. Next is team 7.
Yes, sir.
yes, sir.
Team Bernard, please speak up.
Yes, sir.
Acute
Okay,
onset.
25 female with acute onset lower abdominal pain, adnexal mass on ultrasound. These are the MRI images all labeled.
T1 description all about description diffusion restriction description என்னது torsion தானா? Sir, I am provided with MRI images, different sequences of a female with acute abdomen pain. On first image, T2 weighted coronal, I can see a heterointense lesion involving the right adnexa. Right ovary is not separately visualized. And on T1, contrast heterogeneous. T1 also it appears heterointense. I can see the vascular twisting of fallopian tube. The fallopian tube appears to be twisted. On contrast administration, heterogeneous. There is heterogeneous enhancement. On the lesion is also showing there are a few solid components showing diffusion restriction also, sir. So our diagnosis would be fat the right.
So what is your DD?
Can be a right to ovarian teratoma with torsion, sir.
DD. Other than that, any other diagnosis?
Solid component diffusion restriction can be young woman, can be a dysgerminoma of right ovary.
Key finding on MRI?
There is a diffusion restriction and there is a enhancement of solid components.
Will you do any other blood test before proceeding for any major
tumor markers, sir? Beta HCG.
So you want to add anything on differential?
Tubal ectopica.
So it was very hypervascular if you see on the arterial phase, and there was this hyperintense signal on the T-united images.
Dr. Shah, time is over for this time.
Yeah. Okay.
So I think they won't get any marks for the diagnosis. Finding me, they can get +1. And for the question, Dr. Sharad?
For all the description, everything, maybe beta HC they said, right? So maybe 4 or 5 marks.
Okay, +1, +1, +2 only.
Okay.
+2.
But for a young woman, you should have thought of ectopic.
Yeah, very important.
But not a married one.
Okay, next is team 8.
Sorry.
SMS Hospital, please speak up.
Yes,
sir.
60 female who presented with postmenopausal bleeding, and then they found an incidental lesion on ultrasound in the upper abdomen. You have CT images. Sorry, not labeled, but you should be able to say what these are.
So this is a large, well-defined cystic lesion noted anterior to the left kidney. It is displacing pancreas anteriorly. And sir, there is a enhancing thin septa also noted within it. Sir,
displacing vessel.
So what is the location of the mass? Which organ?
So can be pancreatic involvement, pancreas involvement in it.
Yeah, so coronal image will have a clue if you see that. You can see the stretched out pancreatic tissue around it.
Yes, sir.
Claw sign.
It is forming claw sign with pancreas.
Yeah.
Differential cystic.
Okay, so the questions.
Sir, in an elderly female, this much of large cystic lesion
in pancreatic
tail region can be this large cystic lesion. Sir, can it be serous cystadenoma?
No, serous
kind of thing.
Give the DD now. I'm not asking you the diagnosis now. First, give
Sir,
the
the time is over. Time is over for this team.
So DD would be like more in terms of theory. Pseudocyst is the most common cause, so you can keep pseudocyst, pancreatic cystic tumors. Like here, I would say mucinous, not serous, because it's a big cavity. Serous is usually multicystic. 90% times they are multicystic and they are not such huge cavities. So I would have called this mucinous cystadenoma, but on surgery this was a cancer. Though I will agree there are no solid elements to suggest that, but mucinous cystadenoma is a good diagnosis. Management, we couldn't go up to that point because you didn't give the DD.
Then sir, you are mute.
They will get only +2 for the description.
They
SMS
did say
hospital team
serous
8.
cystadenoma, so maybe 4.
Okay. Okay, then +5, +5.
2 for findings, 2 for diagnosis, or 3 for diagnosis? You're saying
3
we
for
will give 3.
diagnosis, 2 for findings. So
And
+5.
0 for, okay.
Yeah.
SMS hospital team 8 +5.
Okay, so we thank you, Dr. Sharath, for your excellent cases in this session, and we will continue with the remaining teams as Dr. Tharani will join. Dr. Tharani, you have to share your screen now.
Sorry, I'll just stop sharing.
Yes.
Team 9 Star Wizards, please speak up.
Dr. Tharani?
Yes, sir.
Yeah, and next is team 9. Team 9.
Yes, sir. Yes, sir.
Yes.
Can you see my screen?
Yes, yes.
ma'am.
Yes, ma'am. Yeah.
Pin team 9.
It's a 25-year-old man who presented to the ER with vomiting and abdominal pain. The right suprarenal gland appears to be enlarged with splenomegaly noted, and the bones appears to be somewhat osteopenic. Okay. So possibly adrenal lesion and the extramedullary hematopoiesis, paraspinal widening is also seen, possibly extramedullary hematopoiesis and right suprarenal gland tumor. What suprarenal tumor? Possibly pheochromocytoma. Pheochromocytoma or adenoid cystic carcinoma. Calcification extramedullary hematopoiesis. Or simple vomiting and abdominal pain. You've got most of the findings right. You're trying to fit in the right suprarenal lesions.
Or it might be because of a suspicious lesion in the right lobe of liver, left lobe of liver noted.
Left lobe of liver?
Right lobe of liver.
How is the appearance of the suprarenal lesions? Is it similar to something else?
It's similar to that of
Liver extramedullary
extramedullary hematopoiesis, like a lipoma, myelolipoma, or like
co-structural marking is
fat, poor.
Time is over for this team.
Yeah, okay, you're right in the diagnosis. It is extramedullary hematopoiesis, but the suprarenal lesions are also part of the extramedullary hematopoiesis. They look exactly like the paraspinal lesions. Okay, so what are the common and uncommon sites of skull bones, paranasal sinuses, lymph nodes,
spleen?
What are the common ones? Common ones are the liver spleen. Yeah. Paraspinal region.
Skull bones.
Skull bones. Sites? Uncommon sites, lymph nodes. Lymph nodes, thigh. Sometimes things. Yes, lymph nodes. Sometimes thymus.
Rarely by longitudinal appendicular skeleton, rarely.
Uncommon sites. So I think we can move on. There are quite a few uncommon sites, including the mediastinum, suprarenal glands, kidneys, perinephric soft tissues like
Soft tissues.
presacral location. All of those are uncommon locations. So I think we can give full marks for key findings, diagnosis, and maybe partial for the follow-up. 2 marks for the follow-up. So 9 out of 10?
No, 8 out of 10.
8 of
8, okay.
Total 8 out of 10 because we partially correct for the related questions. So 8 out of 10. Team 9 is plus 8. Next is
team 9 plus
next
8.
is team 10.
Yes, sir.
Mad Rats, team 10, please speak up.
Yes, sir. Yes, sir. In these coronal sections of the 59-year-old male with jaundice and abdominal pain, we can see dilatation of CBD, which is irregular, and diffuse thickening of the CBD wall on both circumferentially, which is seen, which is intrahepatic biliary radical dilatation. The GB is also very dilated in this. Okay. This is over distended. GB is over distended. So I would like to give a with old age. I would first is a cholangiocarcinoma, and second will be a primary sclerosing cholangitis. Second differential. IgG4 will be the differential diagnosis. First would be a cholangiocarcinoma.
Can you give a better description of the bile duct?
There is circumferential concentric mural thickening, irregular mural thickening involving periductal mural thickening involving the entire common bile duct with irregular intrahepatic biliary radical dilatation.
And CBD dilatation is also there.
Okay, so cholangiocarcinoma, do you expect CBD dilatation at the level of thickening?
No, ma'am.
Okay. So I think your first differential I would not accept in this.
Then primary sclerosing cholangitis, that would be more possible in this kind of situation rather than cholangiocarcinoma. We'll be keeping PSC as a first diagnosis.
PSC as first, and second is
IgG4.
IgG4, and third is cholangio, is it? Okay.
Yes,
So PSC, you must have seen enough number of PSC cases. So we don't usually see this almost massive or mass-like wall thickening in PSC ever. We do see mild degree of IHBRD, and you do not expect any dilatation at the level of thickening is not in terms of a sclerosing, highly sclerosing disease, okay, which includes cholangiocarcinoma and PSC. So IgG4 is the diagnosis in this case. I think you can get partial marks for answering that. Description, I would say partial again. The most important giveaway finding in this case is because the lumen is maintained despite this much significant wall thickening. Okay.
Okay.
Ma'am, do you have a theoretical question? Do you have a theoretical question?
Yeah, we have a theoretical question. One more finding is the lesser degree of IHPRD. This much of wall thickening, if it was cholangiocarcinoma, you'd expect massive.
Okay. Question, please.
Follow-up question: how do you diagnose biliary IgG4?
Diagnostic criteria: the serum IgG4 level should be more than 1,500 milligram. That should be extra.
There are various diagnostic. There are different parameters you can use for diagnosis. One is serum IgG4 levels. What are the others?
1,500, more than 1,500 is the level for serum IgG4.
The absolute value.
1,500, no?
I'm not interested in the absolute values. What are the different parameters you use?
Other systemic findings.
Time is over for
other
this
systemic findings will also be the seen.
Can
IgG4 pancreatitis will be there. The sausage pancreas will be there, surrounded by the hypotenuse halo, which will be seen in the city. And pulmonary involvement will also be there.
Okay, other organ involvement.
Yes, ma'am. Other organ involvement.
Serum IgG4 level elevation 1. So you've given me 2 out of 4. At least 4 you should tell me.
Yes.
Okay, I think their time is over, so they will get +5, total marks of +5. +1, +3, +1, +5 marks.
So briefly to cover, there are 4 major diagnostic criteria. One is imaging, classical imaging findings. One is serum IgG4 levels. One is tissue IgG4. And third is histopathology. The third is other organ involvement, and fourth histopathology. Treatment is steroid. Okay, so there you can look it up online, the details of it. This is the same patient reduced spontaneously after 2 weeks, and lumen has opened up completely. In this case, there's no pancreas involvement. So we need not always have pancreas involvement. So don't look for, you should look for it, but it need not always be there.
Next team 11.
Team 11 Star Crusaders, please speak.
Ill-defined soft tissue, fatty dense with the soft tissue components noted along the mesenteric region, pushing the bowels to one side, and there is a herniation of the lesion into the inguinal region. On the contrast, it shows ill-defined soft tissue enhancement.
Where is the lesion?
Right iliac fossa.
I mean, which structure?
Mesenteric region.
Does mesentery go into inguinal region?
Omental fatty lesion with a soft tissue component which shows an enhancement, and the lesion appears to radiate along the
In the
right
description, I think there's
inguinal.
one finding that I'm looking for. Look at the third axial image. Can you see anything standing out?
Starting with the nodal few common.
Can you see my cursor?
Yes.
What is this?
No, ma'am. No cursor.
What is this? Oh, sorry.
Twisting.
Can you see the cursor now?
Twisting of this is talk like twisting hyperdense lesion is seen.
Do you have a diagnosis?
Sclerosis. Sclerosing omental deposits. Omental herniation with twisting of omentum.
What is it called?
Torsion. Necrosis. Fat necrosis. Omental fat necrosis.
Okay. You've got it all partly right, both description and the diagnosis partly right. So this
Dr.
is
Tarani, the time is over for this team.
vessels.
Yeah.
It's an omental torsion.
Torsion. We said torsion, ma'am. Torsion.
That's with a lot of prompting, and parallelly your colleague also mentioned necrosis. I mean fat necrosis. So I think you get it partly right. Okay. Follow-up question. What are the types of omental torsion?
Omental torsion types.
Torsion, I mean, it's not imaging types. It's more of etiological or pathophysiological types.
Can be due to vascular cause and any lesion causing extra omental lesion causing the torsion, or a vascular cause of twisting.
I'm sorry, I don't think we can get that. So there's primary omental torsion and secondary. So secondary is the most common, which happens because of inguinal hernia, most commonly, or when there are adhesions due to any surgical scar. Primary omental torsion, if there's any inherent congenital anomaly of the omentum itself. Okay.
They get +4 marks to team 11. So next is team 12. Team 12.
Yes, sir.
IML second year, please speak up.
Yes, sir. Yes. There is a ill-defined tissue, non-enhancing area in the body and tail of pancreas with fat stranding, with air densities seen in the wall of the stomach, with with some free fluid in the hepatorenal pouch. This is stone. With pneumobilia.
And hyperdense content are seen within the duodenum and also the stomach.
Pancreatitis.
Gallstone-induced pancreatitis. And pneumobilia.
Sorry, let me stop you there. This hyperdense structure is NJ tube.
Pneumobilia with ma'am, air density in the CVD. एक मिनट थ्रोम्बोसिस देखियो थ्रोम्बोसिस
पोर्टल उसका स्प्लीनिक वेन का
स्प्लीनिक
वेन थ्रोम्बोसिस
So
you got
necrotizing pancreatitis, emphysemitis, gastritis.
necrotizing pancreatitis. You said air in the gastric wall and this air in the
Portal venous gas.
yes. Okay.
Portal.
Splenic vein thrombosis that is depicted here. So your diagnosis?
Portal venous gas, ischemic में portal venous gas,
Ischemic what?
Arterial ischemia leading to necrotizing pancreatitis and
Ma'am, time is over for this team. Time is over for this team.
Okay. And move on. The diagnosis is acute necrotizing pancreatitis, splenic vein thrombosis resulting in gastric ischemia or ischemic gastritis. I think we can get for the findings, we can give them full marks. For diagnosis, I think partial marks.
+5.
Yeah.
And then question.
Question DDs for intramural air. So one is gastric ischemia. What are the other two?
Emphysematous gastritis.
Emphysematous gastritis. Right. Third one, it's a more.
Ma'am, didn't hear you.
Third one is a more benign entity.
वो COPD in obstructive COPD or
what is it called?
Connective tissue disorders also have.
What is it called?
Okay,
we'll give you the points. I think it's called gastric emphysema. So that's a very benign version. We just see air and nothing else. There are almost no symptoms in those patients. What we see is gastric ischemia.
You're on the street.
What we see is gastric ischemia. Third, a more malignant version is or a more severe version is emphysematous gastritis. I think you can give full marks for the third follow-up questions.
Total of +8. +8.
Team 12 RML +8.
Next team.
Team 13. Wim,
Sir.
you want to speak up?
Yes, sir. Team 13. Sir, contrast image, the coronal section and axial section. As the pancreas, agents is the partial muscle. Results are not like that. Treatments, treatments, okay. Okay. Sir, body of the pancreas is non-visualized.
No, this is an oblique coronal image, so you may not see the body.
Multiple okay. Nodular lesions are seen in the region of the in the periportal region, sir. In the periportal region.
What are they?
And also enhancing, ma'am. They are all enhancing neuroendocrine tumor. Can be a neuroendocrine tumor.
Okay, that's not the primary pathology in this case, so look elsewhere. They're all lymph nodes.
Yes, ma'am. Multiple periportal and perigastric lymph nodes.
They're all lymph nodes. Ignore that. Go. There's another primary pathology.
Carcinoid. Ma'am, enhancing lesion noted in the distal ileal region, ma'am.
Can you which part of the screen? Distal ileal?
Ileal lobes, ma'am, at the ascending colon.
Oh, that's normal.
Yes.
Can you see this? What is this? The same thing is here. It's a difficult case, but I'm pointing to the pathology.
Multiple hyper-enhancing lesions are seen in the mesentery.
It's a single lesion, same thing on both images.
Dr. Thalani, their time is over.
Mesenteric paniculitis, ma'am.
No, sorry, I won't give you that. It's an enhancing lesion. So hyper-enhancing lesion, it's bleeding up to the bowel wall, into the bowel wall also. That's why these coronal oblique images needed to depict it. And can you see this linear hypodensity in that?
Yes, ma'am.
Organ does it look like?
GIT, ma'am. Gut, gist.
No, no.
Dorsal is
What organ does it look like? We are just discussing for learning sake now. Elongated, enhancing with the internal duct.
pancreas, ma'am.
Yeah, it's an ectopic or heterotopic pancreas.
Ectopic pancreas.
Pancreatitis. Okay. So in fact, this patient had come back later with another episode of acute pancreatitis of the ectopic pancreas.
Ectopic pancreas. Okay. Yes, ma'am.
Should we get this or no?
They won't get marks for the question now.
Oh.
Next team.
So their total mark is
Nitin sir, marking?
Yeah.
Description, they can get partial marks.
+1. Nothing for diagnosis. Okay, though they had a difficult one.
Yeah,
So
so
this is
yeah.
so it is
So maybe we can give them the option of answering the follow-up
okay.
question.
I think so. Yes, yes. So you can answer this question.
When do you call it heterotopic pancreas? The previous team 13, I guess.
Team 13.
Ectopic location of the glands that we usually pick it on the nuclear scan, ma'am. Technician 99 scan.
No. Definition means not on which scan and all that. Ectopic location, okay.
The two separate ducts will be seen.
Yeah. So no
training
continuity
the
of
CBD.
ducts and no continuity of vessels either. Okay.
Yes, ma'am.
Okay. Which other? Do you know of any common locations where it can occur?
Ma'am, distal ileal region, Meckel's region, ma'am.
Okay. Meckel's distal ileum is fine. Most common is upper GI.
Yes, ma'am.
So need not be in the mesentery. It can just be seen as a polypoidal lesion in the upper GI tract. We won't know it is ectopic pancreas until it is biopsy.
Yes, ma'am.
So we can give, I think, partial marks.
+1 and +1. So total of +2 marks for them only. +2.
Wims Warrior
Next is
+2.
Team 14.
Yes, sir.
Speak up. Wild card.
So there's one more image. I'll quickly skip this. So look carefully, just for 10 seconds.
Team 14.
Ankit,
Yes. Okay.
Should we discuss?
Okay, moving on.
Okay.
What did you see on the X-ray?
Multiple air fluid levels were seen with the dilated bubble loops, concentrated in the left hemiabdomen.
Okay, this arrow.
On the CT, the bubble characteristics are of jejunum with valvular conjunctivis.
Okay. The arrow is pointing to the.
Arrow is pointing to a narrowed segment of the bubble, likely a stricture, with the upstream proximal dilatation of the jejunal loops and air fluid levels.
There's one more key finding on these images. If you pick it up, you'll know the answer.
Decent calculate. Few hyperdense foci are noted in one of the bubble loops in the third image on the left side.
Where is that the same thing seen on the second image?
Yes, it's seen on the second image, just anterior to the arrow.
Yeah, so anterior to, is it in a bubble?
No.
It's outside the center.
Is there a VP shunt?
VP shunt with
Full diagnosis, please.
they call it something.
VP shunt and there is intestinal obstruction.
Why would a VP shunt cause a bowel obstruction?
Internal hernia, anything?
No, I'm not showing you any internal hernia. What is around the VP shunt in the third image?
The scarring. The scarring and thickening of the bowel wall around it and mesenteric thickening.
At the transition point, all you're seeing is a collapsed bowel. It's not abnormally enhancing. There's no focal mass lesion. So when do you see such just acute collapse or kink and nothing else?
Dr. Tarani, their time is over.
Yeah. So it's an adhesive intestinal obstruction caused by peritonitis. So this is peritonitis because of PP shunt. Pseudocysts are there. Okay, so I think description half and diagnosis also half. Intestinal obstruction is the easiest finding. I don't think we should give points for that.
And
Okay. Do you know the possible mechanisms in which it causes, how BP shunt can cause peritonitis or peritoneal inflammation? No guesses?
Okay, so their time is over.
Yeah. It can be mechanical irritation. It can be CSF high protein that can cause chemical inflammation. And often it is because of infection that results in a sheath around the VP shunt, pseudocysts, and diffuse peritonitis. Yeah.
So they get +1, +3. So total of +4 points.
Yes.
+4 for team 14, and now last is team 15. Team 15.
Emerald, speak up.
It's a plain radiograph actually showing a calcification in the left iliac region, and also see surrounding hypo-loosened area. In the CT image, in the sagittal image, also shows the appearance of calcification, which is looking like a fetal long bones with surrounding hypodense collection, and there is also a fat component also seen. In the volume rendering image, we are able to appreciate a fetus-like structure in the left iliac fossa inside the peritoneum. So it's likely a diagnosis of fetus in vitro.
Do you have a differential diagnosis?
Since it's a calcifications and compounds, like you can consider teratoma also.
Okay, what,
when we just have
what kind of teratoma? Any
radiograph.
adjective,
Ma'am?
any adjective you want to use for teratoma? Any descriptive?
Mature teratomas.
Fetiform teratoma. Okay, I'll give you that. Where is the location? Abdomen. Which compartment?
So we're able to appreciate it is actually pushing the kidneys to the left posteriorly. So it is likely to be in the left retroperitoneal area, possibly.
Okay, yeah, it's a large left retroperitoneal mass, and fetus in fetu is absolutely the right answer. And differential diagnosis is of a teratoma, fetiform teratoma. How do you explain this? What is fetus in fetu?
During embryogenesis, the pluripotent cells.
That is for teratoma, right?
Migration anomaly could be cell migration.
Okay, so you won't get marks for the follow-up question. You get full marks for the rest. But I'll give you a clue. What is fetus in fetu? What does the term mean?
Appearance of an embryo inside an embryo.
Not an appearance. It is an embryo inside another fetus. It is a fetus inside another fetus. So during embryogenesis, when there is monochorionic diamniotic twins, one fetus resorbs the other fetus, other underdeveloped fetus. So its sister or brother, it resorbs or absorbs into its predominantly retroperitoneal cavity. So it's actually a true fetus, underdeveloped, malformed fetus inside another otherwise normally developing fetus. So they often present as newborns or at a young age with a mass. This particular patient presented at 30-something years of age with lump, and they all thought it was EHPV. On ultrasound, it was very hyperechoic. They thought it was spleen, and referred to a center as EHPDO and masseter. Okay, I think that's the last one.
So they get plus 7 marks for this. Plus 7. So we come to the end of this round 3. And thank you very much, Dr. Tharani, for the excellent questions and the important teaching points as well. So moving to the last round, round 4. Dr. Srijita, please share your screen. Dr. Srijita Ghosh.
Yes. What will the sequence? Team 15 or team first?
We will start from 1 to 15 only again.
Now we will start from 1 to 15. That will be easier.
Completely
Team 1,
randomized.
X-rayed. Please speak up. Team 1.
I think Tharani needs to
sorry, what do I?
stop sharing the.
Yeah.
Dr. Tharani has to stop
I-
sharing.
It's showing me as not sharing yet. So. Can someone guide me? I'm being shown as not sharing.
There's something matrix application important guidelines that can be seen still.
No, Dr. Srijita, you have to click on the share screen green button at the bottom.
Yeah, the moment I'm doing it, the someone else is sharing. The host isn't allowing multiple presenter sharing for this meeting. That's what it's saying.
Mr. Dr. Tharani, you are yet not completely unshared. Actually, this AIG logo is, I think, coming.
Dr. Tharani, you have to stop sharing.
I'm sorry. Wait, sorry, I'm sharing now.
Till we can see your screen, that's why. Can you click on the share button again and just click it and say stop sharing?
Now I can. Now I'll do it. Yeah.
Sorry.
Okay. Thank you very much. We can start, Dr. Srijita, with team 1.
My screen can be. Can my screen be seen?
Yes, we can see the grass.
And am I audible?
Yes.
Okay, coming to the last session, first of all, thank you, Team AOCR, for this. And after a marathon session of such lovely cases, I'll come to a relatively easier. My questions are all spots. They are all spots. So with the fag end, it's almost 10 o'clock. We'll keep it to 1.5 minutes. Very, very, very objective.
Yes,
finish
that is
fast
better.
and we'll go off. Yeah, we'll finish
Team
it very,
1,
very fast.
Team 1,
Team 1 X-ray, please speak up. Team 1 X-ray.
Who's team 1?
Yes,
I can
Team
just see my
1.
screen. I can't see anybody. So I need to hear you speaking.
Team
Team 1, are you
please
there?
speak up.
Yeah.
X-rayed.
Okay.
Yes,
Coming to the
Team
first
1.
question. Okay, Nidhi and Ankur, it will be like 3 sections. Findings, number 1. Number 2 is diagnosis. Number 3, if at all I have any associated questions, right? So I'll start. Okay.
Ankit, please pin team 1.
Yes, and I'll just tell you the team 1. I'm telling you the history. A 32-year-old male presents with injury to the shoulder, feeling of instability.
Just a minute, Dr. Srijita, sorry to interrupt. Before we start this round, I want Dr. Nidhi to just give the total scores so that everyone is clear about their scores.
Yes.
Dr. Nitin, I will be needing at least 2 minutes for that. So we can tell.
Okay, we can finish this first team then.
Team 1, unmute
I want to tally
yourself.
it with your mark list.
Okay, so I'll finish off the first team. At that by that time, Nidhi can complete, right?
Yes. Start with team 1.
And team 1, you please do. The sound should be loud because I'm not being able to hear it. Nothing is written on my screen. Only there are films for everything I'll be speaking. So you should also hear me. Okay, starting. Case 1. First, listen to me. This is a 32-year-old male presenting with injury to the shoulder, pain with feeling of instability. 20 seconds, just go through it. Your first question will be enumerate the findings, all the findings. Louder, please.
There is mild joint effusion noted, and there is some T2 star hyperintensity noted within the anteromedial aspect of the humeral head. Likely suggestive of some contusion.
Likely suggestive of?
Contusion.
Bone contusion. Okay.
Likely
Next.
due to trauma.
Okay.
The supraspinatus tendon appears to be fine. There is biceps tendon. The biceps tendon appears to be in the groove and not displaced. And
any other findings? I'll give you,
There is
what are the two, what are the
interconnected
two, I'll tell you there are two classic findings here. What has happened?
in the
Two classic
subscapularis
findings. Tell me.
subscapularis tendon, partial tear of the subscapularis tendon.
Anything
At
else?
the site of its attachment. And inferoabdominal. And infero
Dr. Sanjita, time is over. 1 minute.
glenoid
30
cavity.
So
seconds.
I'll enumerate the findings. We are finding, I have told you the patient is feeling some kind of instability. What are the findings is we are seeing an area of flattening. This is not exactly a defect, but a flattening in the anteromedial humeral head. And we are seeing a posterior inferior labral lesion over here. Okay. So it is just the reverse of what happens in an anterior dislocation. This is a classic case of posterior dislocation of shoulder. So neither have you got your findings right, nor have you got your diagnosis right. So is there any point of going to associated question?
No, ma'am. We will not.
So that's it. So Nidhi, do you want to enumerate the marks previously, or should I go ahead?
Let's go ahead, and I have already done this. Dr. Nitin, you tell me. We need to tell the marks right here.
Just Dr. Nidhi, you just tell them the score so that they know what is the cumulative score at this moment.
So we are giving 0 to X-ray this round?
Yes.
Team 1?
We can give yes, 0 to the entire thing.
Okay.
Okay, but the results that I'm telling you, it's only for the 3 rounds. I'm not considering the 4th round for the X-ray. Okay.
Yeah.
So the total marks are 10 for the team 1, 14 for team 2. Dr. Nitin, do I need to tell the division also for the 3 rounds?
No, total.
Okay, 10 for team 1, 14 for team 2, 23 for team 3, 27 for team 4, 15 for team 5, 14 for team 6, 21 team 7, 10 team 8, 25 team 9, 17 team 10, 17 team 11, 25 team 12, 21 team 13, 22 team 14, and 22 team 15.
Okay, so we continue with team 2 now, Dr. Srijita.
Okay.
Team 2.
So case number 2. Case number 2. Just 10 seconds for you to see before I start questioning. What is your finding? Tell me, what is your finding?
Radiograph of 4 tapir and oblique view shows flattening of the head of second metatarsal bone, likely suggests Friedberg disease. Osteonecrosis of the head of second metatarsal bone, Friedberg.
Okay. So yes, you have got it. If there's a collapse of the second metatarsal head. And what is this condition called?
Friedberg's.
Friedberg's what actually? What is it called actually? Tell me the. No, there's a Friedberg's something called. What is the full thing called? Friedberg's? Infraction. Many of you get this in exams, and I have found students calling it Friedberg's infarction. No, it's Friedberg's infraction. Yes, it is osteochondrosis of the metatarsal head. Since you've got your findings right, I'll show you up this corresponding MR, and I'll ask you, let's see, one associated question. If a similar condition is seen in the hand, what is it called?
Detach.
Excellent. Excellent. Very good. So full 10 marks to this team.
Okay. Full 10 marks?
Yes, complete 10 marks. Okay.
Fantastic.
Very easy.
10 marks.
Absolutely 10 marks. Okay. Now, painless
Team 3,
swelling
take
in
it
the
on.
painless swelling of a young person in the inferomedial aspect of the thigh. Tell me the complete findings, including what is the location. Louder, please.
I have not started telling, ma'am.
Oh, acha, you're discussing amongst yourselves. Okay, fine.
फैट सप्रेशन हो रहा है. ओके, फैट है सेंट्रली, फैट सप्रेशन, लाइपोमाइटिस है.
लाइपोमाइटिस कंडीशन होती है ना जिसमें सब थिकनिंग होती है.
Please start describing.
Yes, ma'am. There's a well-defined oval-shaped lipomatous. It's showing a suppression on fat sequences. There's a central hypointensity noted in the lesion.
Where is it located?
It's located in the ant. in the anterior aspect, in the deep subcutaneous intramuscular plane.
Which muscle?
Uh,
I told you this is the lower aspect of the thigh.
Lower aspect of the thigh. Biceps. Adductor. Inframedial.
Biceps?
Biceps femoris, ma'am.
You think this is medial or lateral?
This is medial. Medial.
Yeah, it's medial. So?
Vastus medialis muscle.
Yes.
Intramuscular lipoma.
What is this central hypointensity within? What is this?
Dr. Srijita, time is over 1.5 minutes.
Okay. So what is your diagnosis? Complete diagnosis.
Intramuscular lipoma.
Okay. Okay. So actually the central hypointensity is corresponding to calcification. So you're right about your description. You were wrong about your location. So that is something very important when you're in the exam. And one associated question is when will you call it turning malignant? What are the things you will which will suggest that
Clinically there is sudden increase in size, there's pain associated.
And imaging wise,
there can be enhancement, there can be foci of restriction of diffusion, infiltration into the surrounding tissues.
Soft tissue component, sudden increase. Very good. So they just got they got the site wrong. So I would give them 9 out of 10.
Let's do it
is
8.
correct.
8. But that there will be wrong calculation. We will do it 8.
No, the description was, diagnosis was +5, description was partly correct, so 5 + 1 6, and answer was correct, so +9.
You will give
Plus
complete
9.
marks for the diagnosis?
+9.
Yeah,
+5.
the diagnosis is correct.
+5,
Take it
+1,
odds, +9.
+9.
Team 3 +9. Take it odds.
Okay, finished?
Sir,
Okay. Next case.
Saraka, speak up. Saraka, speak up.
Yes, we are here.
So, a 28-year-old male presents with injury in the wrist and pain in the radial aspect. So, what are your soft tissue findings?
Ma'am, on the MR images that have been provided, what is seen is an increase in the scapholunate distance is seen, and along the scaphoid head, there is an area of altered intensity wherein it is appearing hypointense on all the provided sequences. Also on the lateral image, we see that there's a dorsal tilt of the lunate bone that is seen. And with the dorsal tilt of the lunate bone, there is no obvious
dislocation नहीं है.
So what is your complete diagnosis?
Ma'am, there is a scapholunate dissociation with a olar tilt. Dorsal tilt. Dorsal tilt.
Capitate angle is also
Disi hoga.
Okay, very good. Very good. So you've got your description right. You've got your diagnosis right. Now your final thing, I'll give you one. So this thing, suppose what X-ray will clinch the diagnosis? What is the X-ray called, which will show the diagnosis?
Ma'am, generally,
what view is taken?
On the lateral view, we measure the angles, ma'am, and then
no, there is a specific view which shows a particular sign. What is that view and what is that sign called?
Sign is over. Sign, ma'am, but
time is over. It is a clenched fist view which shows the Terry Thomas sign. Okay, so you've just got the last part not right. So Nidhi, they will come
+7.
+7.
Okay,
plus
fine.
7. 2 for the
Done.
findings and 5 for the diagnosis.
Okay, fine.
Saraka, team 4 7.
Okay, coming to case number 5.
Team 5, Vadamalian Hospital. Speak up. Vadamalian Hospital, speak up.
Yes, sir. Who is this? So the history is a 17-year-old female presents with pain and locking in the knee 6 months post ACL. Tell me all the findings.
SATS T2 and axial PDFS images showing irregular AC areas mounted along the tibial tract of ACL reconstruction. This could be cyclops lesion.
Okay, so you've come,
Fibrosis,
so how do you
arthrofibrosis.
describe it? What is the description you said? Repeat once.
Ill-defined areas of altered signal intensity along the tract of tibial part of ACL extending to joint cavity.
Okay. So yes, there's a degenerated graft with a, how will you describe what you call cyclops? What is it actually looking like?
Arthrofibrosis.
Yes, there's localized arthrofibrosis. It's a nodular lesion posterior to the Hoffa's fat pad. So the diagnosis is cyclops. Can you, okay, so your the findings are right. The description is right. The findings and the diagnosis is right. Can you tell me two conditions why the cyclops can develop in anybody, but two predisposing conditions where the cyclops can develop?
Nailing this angle antenatal to Blusard's line.
Dr. Suji, the time is over for them.
Okay, the
One thing,
predisposing factor, some of the thought about predisposing factor is suppose the ACL, that there's remnant ACL tissue. This is the ACL reconstruction graft. So if the remnant ACL tissue remains, or if there is a too much anteriorly located tibial tunnel, these are few predisposing factors where people have seen that yes, there's a chance of more chance of cyclops formation. Yes, you're right about the rest of the things. So Nidhi, what is the calculation? They didn't get the associated question only.
yes, 2 plus 5 plus 0, 7.
7.
7. Good.
Vadamalan Hospital, team 5, 7.
Okay, next team.
Team 6, Dhanvantri, speak up.
Yes, sir.
Findings. 25-year-old female presents with shoulder pain, weakness in particular movements. Complete findings first.
There is a hyperintense lesion which is noted posterior to the glenoid, likely a paralabral cyst. Then within the scapula, subcapsularis also has some hyperintensities, with a few areas of hyperintensities within.
Anything else?
Within bone there are like linear hypointensities which are there, sir. Which are there, ma'am?
So what is your diagnosis?
No, ma'am.
Okay, fine. So Nidhi, even if time is up, I am coming to an end to this thing.
Time is up.
This is a posterior-superior labral tear with a cyst which is in the spinoglenoid notch area. It is compressing the suprascapular nerve, because of which this is the chest area. This is the subscap. You're seeing an entire edematous infraspinatus. So it is the infraspinatus denervation edema secondarily to the suprascapular nerve compression because of this cyst. Got it? Please be very specific about anatomy when you speak. You're talking about the bones. This is all normal. This is supraspinatus. But what is this? This is the chest area. I mean, this is the subscap, and this is the supraspinatus. So be very specific of what is medial and what is lateral. Otherwise, you'll be in trouble. And the associated question I would have asked is, I'm not asking, you won't be getting marks, that what is another common area for this? That is a suprascapular knot cyst. And if that would have caused compression and denervation edema, would have been seen in both supraspinatus as well as infraspinatus. Okay. So how do we mark this?
No marks, ma'am.
No, they have got the paralabral cyst.
Okay.
So partial finding only. That's it.
+1. +1.
+1.
That's it. Because the complete diagnosis was completely wrong. So that's it.
Team +1. Team 6 +1.
Okay. Okay. So team
Team
7,
7.
who is team 7?
Team Bernard, speak up.
28-year-old male presents with twisting injury of the knee and pain.
Confused.
Yes, ma'am. On sagittal
Radial tear.
sections, there is a
Posterior.
radial tear involving the posterior horn of medial meniscus, and there is also still hyperintensity noted within the posterior aspect of the tibial condyle, suggesting bone contusion, ma'am. And there is a full thickness tear involving the anterior horn of meniscus. So, anything else? Also, I can see some joint effusion noted in the suprapatellar bursa.
This was one of the cases which came as an OSCE very recently in the DNB exam.
Yes, we can, twisting of knee, there could be a...
There is a specific name of this lesion.
Tagons,
No,
critical triad of Vodonag. That would be associated. ACL
Can I go ahead?
Medial meniscus tear, ma'am. Anterior horn complete tear and posterior horn partial tear, ma'am. There's also bone contusion. So MCL could have been tear. So critical triad of Vodonag.
No, you're going all wrong. See, first of all, why are you calling this in one section? You're calling, don't speak about this. What you're seeing
Dr.
is, yes,
Sujita,
this is
posterior horn medial.
okay, anyway, this
so
is
we
the
can tell them.
posterior horn. Look at this fluid signal separating this posterior horn from the capsule. So there's a meniscocapsular separation.
Popliteus
This is
tendon
a
tear,
ramp lesion. This is a ramp lesion.
Ramp lesion.
This is a ramp lesion with associated evenum because of the. So you have to mention the vertical tear in peripheral meniscocapsular region separating. This is a ramp lesion which is very commonly associated with ACL tear. And the importance of this is, if we don't look at this and we don't mention this, and only the ACL is served during the reconstruction, then there'll be a re-tear of the graft because of persistence instability. So ramp is one of the hidden areas you have to see when you have an ACL tear. So Nidhi, what do we mark?
Ma'am, findings can you tell me? Diagnosis is zero hai?
Plus one only.
Plus one.
Plus one, that's it. I'm sorry you didn't get it. Okay, so anyway, read about it.
Team Bernard 7, Team 7 plus 1 score.
Okay, next team,
Team
speak
8
up.
SMS Hospital.
Okay, first enumerate the findings. All the findings.
Ma'am, there is fracture at the distal end of fibula.
And ma'am, there is a joint narrowing.
Fracture, distal and fibula, number 1. Next.
Ma'am, joint narrowing of the...
Joint narrowing of?
Ma'am, that ankle joint narrowing is there, tibiocalcaneal.
What X-ray do you think this is?
This is, ma'am, left.
I'm giving you a hint. This is a weight-bearing X-ray of the foot. The patient has come with trauma. What are the findings? You have spoken about the fracture. What else?
Ma'am,
displacement with the
little subluxation of the tibia from the
tibia and fibula.
So what are the structures injured over here, do you feel?
Possibly the anterior and posterior tibiofibular ligaments, talofibular ligaments.
ATFL. You are talking about ATFL and PTFL injury showing like this.
Ma'am, deltoid ligament.
Have you heard about the ankle mortis? Do you know what is the ankle mortis?
Dr. Sujita, time is over.
Anyway, first of all, this is a weight-bearing X-ray. So when the patient is applying weight, we are seeing, do you see such an increased space over here in the distal tibia? And do you see an increased space over here? If it is a normal patient, we will see the same space all around the ankle mortis in the mortis view done in X-ray weight-bearing. So this is something that everybody, but if you see this increased space and it says this is because of the syndesmotic ligament tear and a deltoid ligament tear, this has happened. Okay. So these are pointers towards soft tissue injury, which needs to be documented by definitely an MR before anything else is done. So this is something, Nidhi, what to do?
They
Partial description.
partial description.
The
The same
main,
as
the
we did for the
radiograph was
plastics.
given for the syndesmotic and the deltoid ligament thing. So they've
+1
only got the
only.
fracture. So mark them
+1.
accordingly.
Plus
+1.
one. Plus one.
+1.
SMS team 8 +1.
Okay.
Team
Team 9,
9.
speak up. Speak up.
Yes, ma'am.
Star Wizards,
Yes,
speak
ma'am.
up.
Yes, ma'am.
Complete diagnosis. Twisting injury. Complete diagnosis. All the findings, please.
Posterior aspect of the medial meniscus shows a
Lateral meniscus.
Medial meniscus shows a vertical tear, and there is a partial unstable tear in the ACL ligament.
Tell me once again, one by one. Tell me once again.
There is a posterior aspect of the lateral condyle, lateral meniscus shows a vertical tear with a partial unstable tear in the ACL ligament. And
So what is this called?
Unhappy triad. If there is a
Does unhappy triad involve
unhappy
lateral
triad
meniscus? Please don't speak something which is going to make your examiner angry. What is this lesion called? There's a name for this lesion. Do you know about it? I have shown you ramp lesion. So do you think?
Risberg and Humphrey ligament.
Risberg repair. So you got it, but you were talking about your sides, the meniscus and all that, which was initially making the examiner angry. So yes, this is an ACL tear with a Risberg rib lesion. What is the Risberg rib lesion? So your associated question. What is the
Capsular
Risberg?
ligament.
Yes,
Capsular
so what,
ligament attaching to the posterior one of the lateral meniscus.
no, I am not talking about what is Risberg ligament. I am saying, why does this Risberg ligament tear occurs when there is an ACL injury? Tell me why.
Dr. Sarijita, time is
Because
over.
the Risberg ligament is posterior to that of the ACL in relation.
So what happens?
Whenever there is an ACL ligament tear, there are high chances of the Risberg ligament tear as well.
Why? What mechanism causes this Risberg?
External rotation. Rotation
No, it is
injuries.
the anterior translation of the tibia, because of which there is a stretch. The Risberg ligament is attached to the posterior horn of lateral meniscus. It gets stretched, and this vertical tear that we see in a lateral meniscus posterior horn because of the ACL tear is called a Risberg rib lesion. It's like a zip lesion, actually. Okay, so they got their findings right in spite of all that medial lateral issues, and they've got the diagnosis right, but they haven't got the associated question right. So, Nidhi?
7 marks.
+7.
Plus seven.
Okay,
7
fine.
marks.
Fine.
Star Wizards team 9 +7.
Yes.
Team 8 SMS. No, sorry.
So, team 10, speak
Team
up.
10.
Yes, ma'am.
Madrads.
Okay. What is this positioning done for? What X-ray is being taken?
It's a flexion X-ray of knee lateral view.
Flexion X-ray. For flexion X-ray.
Mm.
By flexion X-ray.
No. That
was the X-ray.
High rating patella.
Oh, high riding, but
No,
please don't
no,
speak about things which are going to make the examiner angry.
No,
you
no,
don't,
no.
you don't know.
Don't know.
No or no? Do you know or not?
We don't know, ma'am.
This is a PCL stress X-ray. When it is, why is it done? What happens is, just like ACL is sometimes easy to pick up, when there's a PCL old lesion where it is remodeled and the MR is coming as normal because of remodeled but attenuated PCL, but still the clinician can understand that there is a PCL deficiency. This is how the X-ray, the patient is actually put his entire weight on this leg. Okay. And so if this is the normal, see the amount of posterior translation of the tibia. Compare it over here. See this, and compare it over here. See how much it has, the posterior tibial translation has occurred. And that's how he demonstrates the PCL deficiency. And the patient goes for a surgery. There's PCL laxity, but because of remodeling of the PCL looks almost healed. This is importance when you study about ligaments, that when it's an acute injury, you tend to overcall, and when it's in remodeled chronic, we undercall in an MR. So herein lies the importance of stress X-rays. So today's session, I showed you importance of 2 X-rays where soft tissue injuries can be found out on the X-ray. Got it?
Okay.
So a bit of learning for you all, and 0 for Team 10.
0.
Team 10,
Okay,
Madras,
next.
0.
Next is Team 11.
11, speak up.
Star Crusaders, please speak up.
Yes, ma'am.
Okay. Take 10 seconds, 15 seconds to first you see before you. I am telling you, take 10 seconds before you speak.
Okay.
You have to give me a complete diagnosis.
Okay. There's a contusion in the lateral condyle of femur with flipped meniscus over the.
Leave the meniscus, leave the bones. Go ahead.
There is a edema in the soft tissue regions.
Everybody knows I will not give you edema as a quiz question.
MCL ligament injury is present in it.
Yes, okay, go ahead.
MCL ligament
what more is there to this MCL injury? Why I have given you it as a quiz question?
Os Pellegrini.
What are you talking?
MCL
attachment on the tibial side.
MCL injury is present.
Yes, 100%. What has happened? This is a complicated MCL. What has happened? There's a particular name to this. You know or not? Then learn about it. See, this is an MCL tear. Definitely.
Time is over.
Yes. So the femoral attachment of the MCL is okay. What you find about the distal attachment, that after it is torn, it is getting the torn ends are in between the pes anserinus tendons over here. So the torn MCL and the pes anserinus in the middle, that is called a Stener's type of lesion, MCL. And this is one indicator for surgery. Normally, many ACLs, they undergo conservative treatment. But this is one, there are few conditions. Please come to the AOCR and I have my ligaments workshop. I'll tell you all details. I will not cover all details. But one condition where MCL is in the torn ends and the pes anserinus tendon is interposed in between the torn end is an indicator for surgery. So 2 things you have to see. Whenever there's an MCL tear, just mentioning MCL tear is not important. You have to cover the knee to that extent that the torn distal end is seen, and we have to see whether there is interposition in between the pes anserinus tendon. This is called a Stener's lesion of MCL tear. MCL Stener's lesion. Got it?
Yes, ma'am.
So, Nidhi, they have just got MCL tear, but they did not know about this entity. So, what to do?
Yes.
One.
Mark again, same as
the
previous teams.
Got it?
Team 11
So,
Star Crusaders, 1 marks.
Okay. Team 12.
Team 12
sorry,
RML second year. Please speak up.
Say yes. Yes, ma'am. Who is this? Got it? Okay. Complete diagnosis. Findings. First, tell me the findings, then the complete diagnosis.
Hyperintensity.
Very, very common case.
यहाँ पे ये अटैचमेंट देखियो इसकी ठीक है तो ये कौन सी साइड है ये मिडल साइड है ना मिडल फेमोरल कॉन्डाइल के में 3 अटैचमेंट है हाइपर इंटेंसिटी इन द मिडल femoral in the medial side of the
intercondylar.
popliteus tendon ऐसे आता है
popliteus tendon आगे पीछे से आके अटैच करते हैं ना.
These are the two, one after the other.
Golden popliteus.
What has happened and what has it led to? Something has happened and it has led to something.
popliteus tendon
All of you are talking about something, seeing something in the medial side, and you're talking about something in the lateral side. Why is MSK in this halat? Popliteus is medially. First of all, can't you see the fibula? So we are talking about something which is happening in the medial aspect. Can you get that? So why are you talking about popliteus when we are dealing with a pathology in the medial aspect? Can you get it or no?
Huh?
That will also go in attachment.
This is also another
PCL cut.
PCL.
कुछ तो मीडियल जाता है ना
Do you know it or no? Don't know.
No.
This is another entity. This is, and see, this is the, yes, this is the PCL attachment. This is one of them. And this is where the posterior horn of the medial meniscus is supposed to join here. So we are seeing a large gap over here. So this is the posterior root tear of the medial meniscus posterior horn. And that is when it is untreated for a long time, we see a sonk lesion, an insufficiency fracture in the medial femoral condyle with a disproportionate edema. So this is the complication of an untreated posterior root tear of the medial meniscus. So this truncated appearance of this is, see, this area means, and the popliteus tendons on this means this is the posterior most aspect. So the normal meniscus should have come and reached here. It is torn, it is degenerated, it is extruded, and because of this long standing, it has developed into a complicated insufficiency fracture, a sonk or a sponk lesion of the medial meniscus. Got it? So, Nidhi, I don't think we can give any marks.
Exactly.
Okay,
they haven't
zero.
told anything.
Or
Zero?
RML second year, team 12, 0 marks.
Zero. Okay, so
Wins
next
Warriors
team.
13. Team 13.
Next team.
Warriors, pick up.
Yes, ma'am.
Injury to the thumb. A diagnosis, spotter. Tell me, 10 seconds. See, this is the ulnar aspect, this is the radial aspect. Spotter.
Spotter, radial aspect, ulnar collateral ligament, collateral ligament injury, where there is an attachment.
What? Tell me once more.
Ma'am,
Tell me that spotter. What is this
there is
you're seeing?
injury at the
glomus tumor, ma'am.
Glomus tumor.
Ma'am, there is injury at the attachment of the ulnar collateral ligament. Ulnar ligament.
Very good, very good, very good. So what? Tell me the diagnosis. What is this? Tell me the complete diagnosis. Complete diagnosis.
Yes, ma'am. Yes, ma'am. 1 second.
Yes.
Collateral ligament.
Gamekeeper stump.
Yes. What is it called? What is it? What is this called?
Gamekeeper stump. Ulnar collateral ligament.
There is avulsion of the
Name. What is that name?
Name. Yes, name.
Gamekeeper stump.
Tell me.
Stenver's lesion.
You think this is a Stenner's lesion?
No, ma'am. There is a starting name.
No, once you, if you don't speak without, if you say, then you're committed, no?
That.
Dr. Srijita, time is over.
No.
Time is over?
Yes, ma'am.
See, that you're talking about Stenner's means you know what is it. This is a non-Stenner's lesion given as the part of the quiz. When we are seeing this is the thumb at the metacarpophalangeal joint. This is the torn UCL, but can you see this black structure above? So that the adductor aponeurosis is there. So the collateral ligament is beneath. So this is the non-Stenner. Against Yes, and see this against that. This is the ulnar collateral ligament. This is the other hand actually, and it is external, superior to the adductor aponeurosis. That is a sternal lesion. So in particularly this quiz, I kept both sternus MCL and a non-sternus case of thumb so that you have a clear idea. Please read about it.
Yes,
So
ma'am.
see, they got the ulnar collateral ligament. It's just that they didn't get this. So their findings were right, but they didn't get the ultimate diagnosis. So we'll give marks to
2.
this team for the findings.
+2. +2.
Yes.
Wims,
Further
Warriors,
question.
+2.
So
Okay.
further question.
Further question. Any other modality which will show this?
Ma'am, X-ray, ma'am.
X-ray will show sternus lesion?
No, ma'am. You can able to diagnose the this one.
No.
Avulsion.
Ultrasound will show.
Yes, ma'am.
So the extra question also they don't get.
No. They missed the
Why are you
golden
calling
chance.
it an X-ray when we are talking about a soft tissue pathology, Baba?
Yes, ma'am.
अच्छा ठीक है. So
+2.
next.
Team
Okay,
14.
fine.
Team 14 wild card, speak up.
Yes. Speak up before I show the case.
Yes, ma'am. Yes, ma'am.
Got it? Okay. What are the findings? Patient is having very much pain and there is point tenderness in the medial aspect of the ankle. What is your finding over here? What is your finding over here?
What?
What is your main finding in the foot over here? Patient has medial point tenderness, long standing, no acute injury. Just fine. Tell me the structure which is abnormal over here.
Tibial retinaculum tear.
What?
I don't know.
What is this? This is the medial aspect. What is this?
Tibialis.
Tell me.
Tibialis posterior.
Yes, tibialis posterior, tibialis tendon is thickened, right? So it is abnormal. So a person long-standing pain has come with posterior tibialis tendon deficiency and thickness. What is the second structure which you will see? What is the second soft tissue structure whenever you when you see an abnormal PTT tendon? What is the second structure you see and what is it looking like here? This is the PTT tendon thickened. What is the structure which you see whenever there is a PTT tendinitis? Very common.
Flat foot.
Yes. In flat foot.
What? Peroneus longus
What?
and brevis.
Huh?
Peroneus longus and brevis.
Peroneus? No, Baba. You're again going to the lateral side. Whenever there is a posteriorlis tibialis tendon, we will always look at the underlying spring ligament. Look at the underlying spring ligament. It's thickened. So this is very acquired flat foot. Please read about it. When you see a PTT tendinitis, you have to see the spring ligament, and the associated question would be, what X-ray would show you the acquired flat foot? What X-ray will show you? Weight bearing plain X-ray foot. Weight bearing. So Nidhi?
Yes, ma'am. Tough call. You tell me.
1.
1, yeah. 1.
+1.
Okay, last. And the last team?
Emerald, team 15, speak up.
Team
Yes,
15, speak up.
Yes, ma'am. Yes, ma'am.
See, before I go to the image, you just have to tell me 3 things. What is this modality I'm showing you? Number question will be, what is it used for in present times? What? Name 2 body parts it is used for. And number 3, what is the finding? The last will be 2 marks on what is the finding in this case. Okay. What is this? What is this modality?
The contrast orthography.
What contrast orthography? What modality has been used?
Emerald, please speak loudly.
Is it contrast study? Will you appreciate like
contrast orthography. I don't know.
Speak loudly, ma'am cannot hear you. Please.
Is it contrast study with like the contrast inside joint, contrast injection inside joint cavity, and
Contrast injection, and after that the patient has been taken to what modality?
Mara, Specta, Mara, MRL, CT.
Fluoro.
See, if you would have known it, you
Does
would
it
have
say-
spoken it. Tell me.
Is it CT, ma'am?
Why are you asking me in a quiz? That too, AOCR semifinals.
CT.
CT, ma'am.
No, what CT is this?
Dual energy CT.
This is a specific term. This is a cone beam CT arthrography to see the talar dome cartilage. A cone beam CT, which has got specific use in seeing the talar cartilage, but the most of the places, the modality is used for dental and facial X-rays, CTs, basically, CTs. Not routinely used, but this is the best modality to show the articular cartilage flaps. Better than MR. Okay, but most of the areas, but this is the cone beam CT. That you have to use this term in order to get marks in this question. So that's it, Nidhi.
Yes, ma'am. So how will you, I was calculating the other marks, so I couldn't.
No, I cannot. Unless they use the word cone beam, this question cannot carry any marks anyway.
So won't get marks.
Emerald 0. Team 15, Emerald 0. Thank you, ma'am. It was challenging for everybody.
Thank you, Dr. Srijata. It was it was very good session. Though students found it relatively difficult, so they will learn MSK more in
Yes,
coming
because they have a
times.
tendency of not going for the MSK. So my idea was to, so instead of they were doing so fine in chest, abdomen, everything, but they should pay some attention to MSK also.
No, you showed good cases.
Thank you so much.
So we will
Thank you.
we will just, Dr. Nidhi will just announce the top 8 teams. These 8 teams will now rapidly go to the spotter round. So there will be 20 spotters, and we will be having close watch on the teams who are raising the hand first, and they will get the chance. And +1 minus 0.5. Total score for spotter round is 20 marks.
Sir, I think we should announce the top 8 teams and ask the rest of them to leave, because we have to see the hand raising. That will be difficult in so much time.
No, that is the whole purpose of doing this segregation. So after the top 8 teams are announced, the remaining teams have to exit, and they can continue to see the spotters on the YouTube link.
Yes.
But let Dr. Nidhi calculate. I think there is
Dr.
some
Nitin,
tie as well.
Dr. Nitin, I need 2 minutes for that.
Actually, there is some tie. So we had decided to take top 8 teams to the next round, but as there is tie between 3 teams at the 8th position, so we have decided to carry 11 teams to the next round. So these 7 teams, the 4 teams will exit only. And then in the spotter round, we will have the clear top 5 because spotter round will be much more objective and fast. So Dr. Nidhi, can you announce the scores?
Yes, just give me a minute.
I think you can
I will
announce
the
from,
total. I will
no,
announce the
no,
total
from,
scores as team 1 to 15 first, and then we'll
okay,
first I will tell the total scores for all the 15 teams, and then we'll announce the top
okay,
teams that we are going to take to the next round. Team
okay.
1, our total marks are 10. Team 2, total marks are 24. Team 3, Team 4, 34.
Team 3,
5,
Team 3, 32. Team 3.
Team 3, 32. Team 4, 34. Team 5, 22. Team 6, 15. Team 7, 22. Team 8, 11. Team 9, 32. Team 10, 17. Team 11, 18. Team 12, 25. Team 13, 23. Team 14, 23. Team 15, 22.
So there are 3 teams at total score of 22. So I am now
So
these
the
teams.
topmost, I will just tell the top score as well. Team 4 is at the highest score of 34. Team 3rd and Team 9 both are at the score of 32. Team 12 is at the score of 25, and same is for Team 2, which is also at the score of 25. Team 13 and 14 both have a score of 23. These are the clear-cut 7 top teams.
So everyone is clear about their respective scores. Now, Dr. Nidhi, you just mentioned that. Yeah, anyone has any question?
Sir, I'm team 3, sir.
Team 3 is 32 marks. Don't ask any questions about the lost mark. Just ask the actual marks.
Sir, I had a question about the instructions regarding the spotters, sir.
No,
First
just
of all, how
wait.
to? Okay,
Wait,
okay.
we will tell that.
We'll just announce. Please
So,
be
Dr.
patient.
Nidhi, you announce the total, these 4 teams which need to exit now. We are carrying 11 teams to next round. Tell the 4 teams which need to exit now.
Okay, sir. I'm telling. Just a minute.
So,
Team 1.
Team 1, you please exit and join YouTube if you want to see the spotters.
Team 6.
Team 6.
Team 8.
Team 8.
Team 10.
Team 10.
And Team 11. And Team 11.
Total. Okay. 5 teams.
Dr. Gurpreet, you also tally once.
नहीं 4 टीम निकलेगी ना.
हाँ नहीं, डॉक्टर गुरप्रीत से बात हुई थी, अभी उन्होंने कहा था मैं भी एक पे टैली कर रहा हूँ.
4 टीम हो गई ना.
हो गई.
1, 6, 8, 10 and 11.
Team 1, Team 6, Team 8.
Team 1, Team 6, Team 8.
And Team 10, Mad Rats.
11 भी.
11 भी. 5 टीम निकलेगी ना.
11 तो फिर 5 हो गए.
हाँ, I think because there are 3 teams, no, so 10 will only go to the next round.
1 minute.
10 will go to the next round. 5 teams will be exit.
Yeah, 10
you're
teams
right.
will go to next.
5 will
And,
exit.
5 will exit. Yes.
Exactly.
7 teams were clear winners.
Yeah,
Only
and
8th position के लिए 3 था तो वहां पे इश्यू था. तो
वहां पे
5
वो-
teams will exit. ठीक है. 5 teams have exited. Gurpreet, you have to check. In the meantime, I am going to share the screen and just giving you the instructions.
I
There
hope it
will
is
be
very clear. I hope it is very clear which teams are to be exited. I don't have to repeat that.
Dhanvantri, Mad Rats, X-Raid.
I think they have already exited.
SMS Hospital.
1, 6, 8, 10, 11.
And Star
everyone has
Crusaders.
done very good.
Yeah, only
But
10 teams are here. So 5 have already exited.
we have to select the best. So this has to be done. Now, out of the remaining 10 teams, we will start with the spotters. Total 20 spotters, one slide, one spotter. And you have to look at the spotter, and whoever raises the hand first, we should clearly see your hand, and you should start speaking as soon as you get the chance. You don't have to speak anything unless and until you get the chance correctly and clearly. And correct answer +1, wrong answer minus 0.5. If you raise the hand and get the chance and you don't speak anything, then also minus 0.5. If any team doesn't do anything, doesn't raise hand anything, then they will remain at the same score. Is it clear?
So with this, even every team has chance to reach to the top.
Yeah, so you should be aware about your present scores and accordingly take the risk.
Yes, the previous marks will be carried forward.
Yeah.
Excuse me, sir. Sir, can we reattempt if any team gets it wrong?
No. No. Only one. One chance will be given. If the team gives it as a wrong answer, then they will be given 0.5, a minus 0.5, and the question will end there. We'll go to the next question. We will not pass over the question to the next team.
Hello? बोल रहा हूँ, एक मिनट. See, all the coordinators, Dr. Gurpreet, Dr. Nidhi, Dr. Ankur, you should look the cases on the gallery view. We will not pin any of the teams, no pinning. So gallery view, maybe we will be in a best position to look at all the teams at the same time. So select the gallery view from the top. मोर में जाके कहाँ से करते हैं?
वो ऊपर व्यू में एक व्यू का आइकन होगा, उसके साथ आप चूज करोगे तो गैलरी
जहाँ पे वीडियोस आ रहे हैं ना, जहाँ पे वीडियोस आ रहे हैं, वहां पे यू कैन सिलेक्ट द गैलरी
जहाँ
व्यू.
पे मिनिमाइज है ना, मिनिमाइज से बगल में व्यू का है, व्यू में आप गैलरी व्यू पे जाइए और फिर उसको स्लाइड करके आप इधर पीपीटी की तरफ ले आइए, तो वो सारी की सारी स्क्रीन एक ही बार में आ जाएगी, तो 10 के 10 पार्टिसिपेंट्स दिखेंगे आपको. उसी व्यू पे आना है.
And we can make the PPT smaller for us.
Yes.
And
we can slide towards left hand side so that view will be enlarged. And we can see all the participants at one point of time.
50-50 कर लो, 50-50 रेशियो कर लो स्क्रीन में.
And please raise your hand clearly.
And you don't have to speak unless we say the team name. Okay? You don't speak unless we ask you to speak.
Otherwise, that question will abolish. Nobody will get marks for that.
Okay. So we start. Everyone is ready. So question 1.
Team 13.
Team 13.
Team 13.
Sir, left kidney. Sir, renal pelvis is not seen. That's a faceless kidney malrotation.
No, wrong. You can see the normal right kidney, edematous left kidney, and hyperdense left renal vein. This is renal vein thrombosis. Minus 0.5.
0.5 to Wim's Warriors. Minus 0.5 to Wim's Warrior.
Question 2. Be ready.
Wim's Warrior again.
Team 13.
Achilles cardia.
Very good. +1 with pacemaker, of course. So this is Achilles cardia extending along the course of esophagus. Team question 3.
Team 2. Team 2.
Mucocele of left maxillary sinus.
Wrong. That is just a opacification. There is no mucocele. Anything else?
Sir, you have
I think no
tell
chance.
the answer.
You can
No
see a
chance.
cystic lesion in the right masseter muscle, the eccentric nodule, cysticercosis,
MCC of
mesenteric
masseter
muscle,
muscle.
cysticercosis.
So scan testing tube team 2 gets minus 0.5.
0.5. Okay, next is question number 4.
Wims, team 13, Wims Warriors.
Yes.
Team 13, speak up or you will get minus 0.5.
Charcot joints.
Wrong. This is an intra-articular osteochondroma, dysplasia Trevor's disease.
Minus
Dysplasia epiphysalis
0.5.
hemimelica. This is an intra-articular osteochondroma causing deformity of the joint, epiphyseal osteochondroma.
Minus 0.5 to Wims Warriors.
Okay, this was question 4. Now question 5.
Team 5. Team 5.
Please unmute
Please
yourself.
speak up. Unmute and speak fast. Unmute yourself.
Angular pancreas, group pancreatitis causing.
What is the diagnosis?
Angular pancreas causing group pancreatitis.
Yes, very good. Annular pancreas is the correct answer. They get +1.
+1.
Next
Team
is
5
question
+1.
Question 6 is the next. Ready?
Team 5 again. Team 5 again.
Yes.
Speak up.
Please unmute.
Unmute and tube. Speak
So
up.
the shortening of gastroesophageal junction representing lower esophageal malignancy.
Wrong. This a barium swallow study showing a poem procedure with patency of the esophagus. This is a classical appearance of a swallow in a post-poem procedure. Poem procedure is done for achalasia cardia. Read about it. Next
Team
is
5
question.
minus 0.5.
Yes. Next is question 7.
Team 5.
Team 5 again.
Right sciatic nerve thickening.
What is the diagnosis?
Peripheral nerve sheath tumor of right sciatic nerve.
What is the diagnosis?
Neurofibromatosis.
This is
malignant peripheral nerve sheath tumor
of sciatic.
This is actually neurofibromatosis type 5, involving only one side, segmental NF. That's why you can see the.
Neurofibromatosis.
So they get half mark for this, plus 0.5 marks.
Which team?
5. Team 5 plus 5.
Plus 0.5 marks. So next is question 8.
Team Emerald.
Team
15. Team.
Please unmute
and speak. Unmute and speak. Team 15.
Yes, there is a vaginal fistula between. There is a contrast seen into the from the vagina.
Wrong. There is no fistula. This is bladder. This is urethra. And at this point, there is reflux. This is uretrovaginal reflux, not fistula. Minus 0.5.
Team 15 minus 0.5.
Next is question 9.
Team 7. Team 7. Unmute and speak.
Please unmute.
Ulnar no schwannoma, sir.
I will give you another chance.
Neurofibroma ulnar no.
Wrong. There is a pulsation artifact. This is a pseudoaneurysm at the level of hook of the hamate. This is hypothenar hammer syndrome. You read about this. So minus 0.5.
Team 7, Bernard, minus 0.5.
Next is question 10.
Do we have to pass the question?
No taker.
Okay, time is over. So you have to appreciate the difference in the right limb versus left limb. Lengthening of the left limb, thickening of the soft tissue on the left side. So angio-osteohypertrophy of the left limb with collateral channel. So this is Klippel-Trenaunay syndrome of the left lower limb. So next is question 11. Anyone?
No takers.
Sir, pass.
So there is a pineal lesion enhancing mass with multiple subependymal nodules. So this is a pineal gland germinoma with leptomeningeal seedlings. So this is also no one answered this. Next is question 12. History is
Team
important.
5, Vada Malayan.
Team
Team
5.
5, Team 5.
Team 5.
Unmute and speak.
Grade 1 intramural tear involving abdominal aorta, interstitial tear, thoracic,
No.
descending thoracic aorta.
We expect the exact answer.
Intimal flap.
What is the exact
Actually, this is
diagnosis? There is a specific terminology for this. You're
this
right,
is
but
the
there is a
finding
terminology for
only.
this. This is the finding.
Grade 1 injury.
Grade 1 intimal tear.
We can give them half marks.
Half mark can be given. The correct term is minimal aortic injury. Everyone should know about this sudden deceleration, minimal aortic injury, typically small intimal flaps less than 10 mm. Read about it. Plus
0.5,
0.5.
Team 5.
Okay, next is question 13.
Team 15, Emerald. Speak up. Unmute and speak. Team 15.
There's a golden S sign in right side, right upper lobe collapse. It's there with there is a multiple metastatic lesion in the bilateral lung.
Wrong. Golden S means you imply pulmonary mass. This is a thyroid mass. That's why there is focal deviation of the trachea. So carcinoma thyroid with lung mets. Minus 0.5.
Emerald, team 15, minus 0.5.
Next is question 14.
Team 5, Vada
5.
Malaya.
Team 5.
Team 5, unmute and speak.
So then pseudoarthrosis at the level of tibiofibula due to possibly neurofibromatosis.
Diagnosis?
No. They said neurofibromatosis.
No, there is pseudoarthrosis, that is correct. But there is constriction of the soft tissue also. So look at the soft tissue. This is amniotic band syndrome. So minus 0.5. Okay, last 15. Next is question 15. Anyone?
Yes, team 2.
Quadriceps fat pad impingement. Quadriceps fat pad impingement.
Yes,
Quadriceps
very
fat pad.
good. quadriceps fat pad is inflamed because of the impingement. Very good. So they get +1.
Team 2, fantastic you. +1.
Okay, last 5 questions left. Anyone?
No takers, we can pass.
Yes, team 7.
Team 7.
Team 7, Team Bernard. Unmute and speak.
Sir, left femoral head, there is an femoral pit. Left femoral head, sir. There is an
Pit
hernia.
is there on
Pit.
both sides. It
Hernia.
has to be there on both sides. Anything abnormal in the left hip?
Sir, the head and junction of neck of femur, there is a sclerotic lesion, sir.
Diagnosis?
Enchondroma.
Wrong. There is
Remove
AVN, and you can see this track. This is core decompression. This is a follow-up X-ray. AVN followed by core decompression. That's why you see this long track. Okay, -0.5.
Team 7, Team Bernard.
Next is question 17.
Team 7.
Yes.
Team 7, Team Bernard.
Unmute. Please unmute.
Unmute and speak.
Sir, Tolosa Hunt syndrome, left intraorbital, there is enhancement and cavernous sinus enhancement.
Very good, very good. Proptosis and enhancement at the orbital apex without thrombosis. So this is Tolosa-Hunt syndrome. Very good. +1 to team
+1, Team 7.
7. Question 18.
Team 13.
Team 13. Team 13, speak up. Unmute. Unmute.
Cherubism.
Wrong. Cherubism doesn't look like this. It looks more like a fibrous dysplasia. Here we have a lesion in the maxillary bone with multiple vascular channels coarsening. So this was not an easy diagnosis because this is maxillary bone AVM, arteriovenous malformation. So bone is remodeled here. So -0.5.
Team 13,
Next is question
-0.5.
19. Next is question 19. Anyone?
Team
Yes,
7,
team
Team
7.
Bernard. Unmute.
Sir, multiple urethral strictures with dilatation.
Okay, what is the investigation?
AUG, sir.
That is wrong because you can see the penis is here. So this is not a MCU. This is a sinography study. This is a scrotal sinus. So there is no stricture. This is not MCU. The penis is here. This is a sinus in the scrotum and it is running close to the urethra. So wrong answer.
-0.5, Team
-0.5.
7. Chalo, last question.
Last question 20.
Team 7.
Team 7, Team Bernard. Unmute.
Pear-shaped bladder with vesicourethral fistula, sir. Posterior urethral valve. The urinary
There
bladder.
is the valve.
Sir?
Pear-shaped bladder, that is correct. Anything more specific?
Bilateral VUR, grade 5 VUR on both sides, sir.
Yeah, that is also correct. What is the cause?
Sir, there's a mass in the neck of bladder, infiltration, carcinoma.
Pear-shaped bladder is because of the pelvic fibrolipomatosis. Pelvic fibrolipomatosis. You mentioned pear-shaped bladder and VUR, so you will get +0.5 marks. +0.5. So we come to the end of spotter round as well, and just wait for the results, and then we have the top 5 teams.
A long night for everybody. And I would really like to thank Nitin sir, Ankur sir, Gurpreet sir, Nidhi ma'am. They have been here throughout.
Marathon semi-finals.
I think it happens like this only. We think of 2.5 hours, but it stretches
But it was a true test of uh, complete radiology, all kind of skills, presentation, findings, differentials, spotters as well. So now we will have the top 5 teams. Let's see.
I think everybody here is a winner. Everybody has got it. And it is always good to just attempt things rather than not attempt or feel sad about something.
Dr. Nidhi?
I think they are discussing the final tally of scores. And I would also like to thank the quiz masters for today who have stayed here till long. Shrijita ma'am, Tharani ma'am, Sapna ma'am.
Yes.
Shrijita ma'am, how are you? I also learned so much today.
I'm fine. Thank you for always remembering. Dr.
Yeah.
Nitin remembers me always during quiz, and Gaurang, you're always there. And Ankur Bhai is there to save me. I told him I have just 15 questions. If I'm stuck, please help me. So I said, don't worry, I have additional questions with me.
Interesting case. I also learned so much.
Yeah. See you all very soon in Chennai.
Absolutely, absolutely. I think all teams should come. They have already registered, and
Though we have to eliminate teams, but the purpose of this quiz is to create this healthy spirit of learning radiology in an interesting manner. So even if you eliminate today, you prepare and read in this manner that you have to face the quiz next year, something like this.
So we have the final scores.
drum roll.
I will start telling from the team fifth.
Okay.
The 5 teams who have reached to the next level. The team 5, the fifth rank is of team 2, Fantastic Duo. They have scored 24.5.
I think
Okay.
you can also identify your college also. Fantastic duo.
Please unmute. Please unmute.
You speak up your college.
College, Sakra Hospital, sir, Bangalore.
Many
Congratulations.
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 Please inform your HOD.
Many congratulations.
Team 4, the fourth ranking is for team 12 with a score of 25 marks, RLML second years.
Congratulations.
How many marks?
25.
So,
Congratulations. Ram Manohar
Okay.
Loya. Congratulations.
Thank
you. Thank you.
This RML is RML Lucknow?
No, sir.
New
RML
Delhi,
sir.
New Delhi.
RML Delhi.
At
Congratulations.
second rank, there are 2 teams together. One
Okay.
is team 9, which is Star Wizards, and another is team 3, Talkie Tots. Both have 32 marks.
Please unmute yourself. Star Wizards, what is your college?
Stanley Medical College, sir, Chennai.
Okay, and
Talkie
Talkie
Tots?
Tots?
Talkie Tots, what is your college? They are stuck, I
team
think.
3, I think they have some internet issue.
Yes.
No issue.
Talkie Tots, Gaurang, if you know that, which colleges they are from?
Talkie Tots is AMC, AFMC, I think.
Okay.
And the first rank is for fourth team, Charaka, with a total score of 34 marks.
Okay.
First is Charaka.
Congratulations.
Congratulations. From which college? Which
In
city?
Charaka, which college?
AFMC Pune.
AFMC Pune. Okay, great.
And Techie Tours is from which college?
AFMC.
Okay.
Okay. Great. Congratulations.
Congratulations to all the 5 teams. See you at Chennai.
Congratulations, you have done exceptionally well. It was a very, very long and very, very tough quiz throughout, starting from the prelims. And I think there is exceptional work done from our respected quiz master Nitin sir, Nidhi ma'am, Ankur sir. Sir, लोगों ने मजा आ गया.
Thank you so much, everybody. And I think we should call it a night now.
Yes. Long Sunday night and evening.
Hello, okay, bye. Thank you.
Okay.
Thank you all.
Bye. Congratulations once again.
Thank
Congratulations
you,
all
Dr.
once
Nitin,
again.
Dr. Nidhi. You both did with sore throat. You did very tough job and ill health.
Thank you.
Thank you all. And congratulations to all winners.
Thank you.
Hello.
Inform your HODs, they will be very happy.
Okay.
Okay.
Bye
Bye-bye.
bye.
Good night. Bye. Bye.